Okay, let's go again. So the pediatric resuscitation, we are going to focus anaphylaxis, seizing child, septic shock. There can be you will never know that the station how it would be, can be septic shock, can be septic shock is merged with the seizing child. So unless when you run the station, you will know it. Okay. Arrhythmias, it can be brady, it can be tachy, stridor can be crope, can be epiglottitis. So it depends. The most likely, which is encountered in the exam, is croup. Okay, so it's likely to be. It depends on the age. We will come up to that station. Hypothermia is already came twice. Newborn came 2 to 3 times already. Stridor crepes also came many times. The arrhythmia usually the tachy shows also came up. Okay, so our first focus will be the pediatric advanced life support. So this is the algorithm. Everyone should be very familiar with that. I think everyone knows about it as you learn in this PA. The same, you have to once you find the child is in cardiac arrest. So could you please tell me, guys, how would you know the child is in cardiac arrest?
If there is no signs of breathing and the heart rate less than 60 is a cardiac arrest.
Okay, so how you will check the no sign of life? How you check for the pulse in children?
We will check the pulse, which is the axillary. This is the brachial artery.
And you will go for carotid or the femoral. Okay, this is very common children to assess. Okay, so anyway, so you should be very careful when you run the station, usually in children. So you try to go for carotid or go for the femoral or both at the same time. It depends on the child age. Okay. So the same way you will call for help, you will start CPR. It's very important. Here would be the 15 compression 2 1, and then you will go for further to attach a defibrillator. The same way you will go for assessment with them, and if you find is shockable, like the ventricular fibrillation or the pulse lace retag, you will give shock, and that would be 4 joules per kg. Okay. The similar way, the adult, but the difference in doses and the measures. Okay. Okay, so I just want to go very fast about it. I want to show you the important thing which I have written here. How to run the station is if the child is in cardiac arrest. Okay, so this is the same way as adult. You will go inside in the station. As I told you guys, you will have total 9 minutes. The 1 minute outside of the station, you will read the case. Then you will get inside in the station, and you will run it. Okay. The same way is for the adult. Hello, I am Dr. B. I'm one of the senior doctor, or you can say I am the on-call doctor today here in the emergency department. So you will ask the team, could you please introduce yourself and let me know your level of competency. Then the nurse will introduce herself to you. Okay. Or you can ask, can I confirm your name and level of the seniority, or may I confirm your name and grade, please? So you can use any phrase which is easier for you. Once you got it, they will tell you their names and the level. Once you got it, and then you have to move for the next one. Guys, could you please close your the video? Thank you. Okay. So then after that, you will go for the important things which you have to say. We have received following pre-alerts. Okay, you will know the case. How old was the child? It depends. A 5-year-old child is drowning. Its case can be like that if it's relevant to hypothermia or another. Okay, Then you will say, please call the ICU team or pediatrician. It depends. And then you will say, ask the nurse who will manage the airway. Okay, are you happy to manage the airway? It depends. Who will manage the defibrillation, and if needed, if you think so, then you will say, ensure you all are in PP, wash your hands. And then you will say, please, nurse A, prepare following equipment, suction, oxygen, airway trolley, make sure all equipment should work properly. This is the brief preparation, okay? The nurse B, please prepare following equipment, the drugs, cardiac monitor, BP, cough. You will ask her to do that. Once you did, you finish, then you will go for, it depends. Usually, what you guys are hearing that you all the time to perform as a leadership role, it's not all the time the case. Sometimes you have to perform everything by yourself, so you have to be ready for that. If the nurse stops you, don't do that. She's going to take over. That means you have to stand away, and you can verbalize what you want. But whenever you need it, you need to intervene by yourself too. Not every time to stand. If it's clearly mentioned you're the leader of the team, then you have to stand near the bed, the end of the bed, and you can ask the nurse for intervention. So it depends. Then you will go for the next important step. Is the patient here? Is the patient arrived? Is the patient alert? For example, if it's going to cardiac arrest, she will say no, patient is unconscious. Then you will say, please check sign of life, look, listen, feel. But what you have to do, that you have to do. Okay, now I'm going to check for sign of life, look, listen, feel, means you have to act like that. For example, you check the pulse with your 2 fingers on the carotid, on also the femoral, okay, to feel it, and also to close your ear to hear if the patient can breathing or not. Once you confirm that the patient is no sign of life, then you have to go for the high quality CPR. Okay, so that means you will follow the Alice protocol. Okay, and you will give the first the open the airway is the paint. If not open, then you have to head tilt, chin lift, and then you will go for 5 rescue breath. Okay, but in adults, in the peds difference is that there is no rescue breath for the adults. In adults, you have to go for start CPR 30 to 2 vent, 30 compression 2 vent. But in children, you will go for 5 rescue breath. Okay, if the pulse is absent 10 seconds or no sign of life, then start high quality CPR 15 to 2. The same like in the pediatric, the algorithm we have to follow. Okay, so you will go for that and you will ask the nurse to attach the back wall mask like that. Okay, first you will give the fire rescue breath. Please give the fire rescue breath to this child immediately. Thank you. Okay, now still check for the pulse. Okay, is there sign of life? No sign of life. Please start high quality CPR 50 to 2. Okay, and attach with the back wall mask. Connect the back wall mask. Okay, you will say like that, and please expose the chest and connect to the monitor and attach the defibrillator pad to this patient. Okay, nurse A, please insert to large bore cannula, extract the blood for the full blood count. FBC. VBJ, electrolyte and toxicology screen. This you all have to say. And then you have to check the rhythm on monitor. Usually, when you ask a nurse to assess the rhythm, then she will maybe show you the monitor to check it out. Or if you're clever enough, you can look at the monitor by yourself. And if you found this is shockable, then you will go for the shock. But if you found it's the non-shockable, then you will go for adrenaline. So I want to show you how I go from A to here, okay? For example. Okay, I'm going back, okay? I show you how I start this station. I read the case outside. Now I'm inside. Hello, I'm Dr. B. I'm one of the doctors today in this department. May I confirm your name and level of grade, please? Thank you. The nurse will introduce, and then, okay, So please, guys, we have got a pre-alert. The 5-year child is joining, is coming over. He will brought by the paramedics. Please wash your hands and call the ICU team. If not, okay, then you say please call the ICU team and also the wash your hands and wear PPE and call the ICU team. Okay, once you verbalize that or everything, then you go for the. Okay, just could you please prepare following command suction oxygen over trolley. Patient may record the intubation later. Nurse B, please prepare following command drug cardiac monitor BP cuff and resus and sedative drugs, and maybe patient record the shock later. Thank you. Then you move to the patient. Okay, is the patient here today? Is the patient arrived already? Okay, yes. Okay. So could you please tell me, is the patient alert or is the patient conscious? Yeah. No. Okay, no. Okay, please check the sign of life. I have to check the sign of life, look, listen, feel. Okay, I feel the pulse now. Okay, I found it. Okay, the nurse will say, no, there is no pulse, no sign of life. Okay, nurse, okay, thank you. Okay, please, if you haven't called the ICU team still or the pediatrician, please call it now, right now. Or sometimes people say the pediatric, the team, so it's relevant to children, so you have to. Okay, so nurse, we have to start the fire rescue breath for this child. Okay, okay, please give the fire rescue breath. If you know how to give, then you have to take over by yourself to give the fire rescue breath. If the nurse wants to take over, that's good. If not, and then again, you have to check the pulse. If you found that the pulse is still same, okay, there is no change, and also then you have to store the high quality CPO 15 to 2 and ask the nurse to connect with the back wall mask. Please connect the back wall mask with the patient and also expose the chest of the patient and connect to the monitor and attach the defibrillator pipe as soon as possible. Nurse B, please Kate, insert 2 large per cannula to this child and extract the blood for the full blood count UNEs and EVAPG, and make sure the results should be available as soon as possible. Thank you. And now the check. I'm looking at the monitor. Okay, I see is shockable. Okay, please give is a patient is unconscious, so we don't need sedation. Please give the shock synchronous 4 joules per kg, and resume the CPR immediately for 2 minutes. Okay. Meanwhile, I will go for the 4HN40s, which are the 4HN40s. Guys, who can tell me 4HN40s? Anyone know about it?
Hypovolemia,
hypoxia, hypovolemia, hypokalemia or hyperkalemia, hypothermia. These are 4H. And 40s include toxin, thrombosis, tamponade, or tension pneumothorax.
Okay. Now you see this child is you don't know what could be the cause, right? But you have to focus on reversible causes. But here you will know what could be the cause. For example, you want to go for hypothermia or hypovolemia. Nurse, help me to check out the temperature of this patient now. Nurse will check it. Okay, you will see that patient temperature is low, but if the temperature is higher, then you will ask the nurse, could you please store the IV paracetamol for this patient right now? Thank you. As the patient temperature is higher. So these 4HN40s, you need to take the intervention. Okay. For example, in T, you found, for example, if the patient is the drug overdose, if child, maybe he took the mother or the grandmother, the medication is he consider is like candies. In that case, it goes to toxin, right? So the nurse will give you the box of medication, and she will say, "Oh, the parents give me this box of medication. It shows like this." Then you will take, for example, it's the CCB. Then you will go for the antidote for that. Okay, got it. So these all 4HN40s are very important. If the cause is tension pneumothorax of the cardiac arrest in this patient, so then you will go for needle decompression. So these are very, very important. If you don't go for HN40s one by one, then I'm sure you will lose your entire score. And this has really happened in, as I said, in adult resuscitation. This station came up many times. And those who don't go for 4HN40s, they lose their score. So you must go, any patient present to you in cardiac arrest, you must go for HN40s. Now look at this one. Once you find it's shockable, or or non-checkable. Once you say to the nurse, please resume the CPR for 2 minutes, in that 2 minutes, you will go for 4H and 4Ts. Okay? And you will check for hypovolemia, hypothermia, okay, hypokalemia. Once you go for 4H and 4Ts, believe me, the nurse will say, yes, patient has got the sign of life, because they give you the resuscitation in cardiac arrest to find the cause. Once you find the cause and you treat the cause, they will stabilize the patient, okay? Okay, then they will say, okay, patient has got sign of life, okay? And then you will say, okay, I want to reassess the patient. First, you reassess the patient before you hand over. Remember that. Try to reassess the patient before you hand over. It doesn't matter. If you don't hand over, if you didn't say you didn't hand over, you will not lose your score. The important thing is here is that you should follow the algorithm and correctly. Doesn't matter you hand over or not, okay? You need to run the station correct, okay? Don't go, or for example, patient got sign of life, then you have to go for reassessment, A, B, C, D, E. Then you will go for, okay, let's reassess the patient, whatever patient airway, whatever patient breathing, okay, circulation, this way. The important thing, as I said, in adult resuscitation and also in pediatric, 4H and 4T is very important. Here you will know what could be the cause of this cardiac arrest in this patient, okay, to avoid the further deteriorating of this patient or the reversible condition, okay? So I think those guys who has joined a long time before, they should know about this. I think we will practice in the role play also. So it's clear so far, right? Any question in this place?
Yes, Dr. Bindi, I have a question.
Yeah.
If patient is in a cardiac arrest, and how can we know patient is in hyperkalemia without investigations? If we take the investigation, send the investigation, and result came, then we will.
That's what I said. I said already. When you see is when you come up to the CPR, you see in the 15 to 2 ends, and then you come up to, you see the nurse A, please insert 2 large cannula to the blood, FBC, VBG, electrolyte, toxicology screen, right? Once you say that, you will say to the nurse, please get the result as soon as possible. So when you go to hypovolemia, hyperkalemia, in that place, either the nurse will provide you, if it's relevant to that case, maybe she will give you the ECG strip, or maybe you can check on the cardiac monitor, okay? You will see what you will see in hyperkalemia. It will show you the total T waves, and that can indicate also one. Another, the VBG always ready, all the times, if it's relevant to that. Maybe nurse will give you the VBG result, or maybe you can ask, because you already said to the nurse, please get the result as soon as possible. And also in hyperkalemia, if you're not sure, then you can say like that, we are waiting for the result to get as soon as possible. Maybe once you say, maybe the nurse will give you the result. Okay, doctor, what do you want to know from the VBG? Because VBG you can get earlier. So she will tell you, okay, the potassium is, the level is this one, if the ECG is not available. Get it? It will be very, very clear in the exam.
Yes, I got
once, yeah, I don't mean that in 4H and 4Ts, you will suddenly say, of course, the hypovolemia, I say...
Because in cardiac arrest, we have 2 things. Either it is a shockable rhythm, either it is a non-shockable rhythm. So we cannot appreciate hyperkalemia in both levels, actually. So
yes,
we have to wait till electrolytes and VBGs.
Yeah, that's correct, as I said. But I mean, if they have the early ECG, if the nurse, once you ask her, maybe she can provide you if she wants to give in that time. But otherwise, you have to, as I said before, in adult resuscitation, that the hyperkalemia, we need to wait for the VBG or the blood result. As I said, if you watch my previous, so the same you can say it here. But so it depends if they can give you anything, and once they give you the VBG earlier, so that's great, and you can get it. This all things depends. For example, hypothermia, you will ask the nurse, please can you check the temperature for me, and she will check and then give you. So it's the same in hyperkalemia. You will ask the nurse, could you please, do we have the blood result? Do we have anything? Maybe she will give you, or do we have any ECG previously? Maybe she can give you that, and you can get an idea what could be the cause. Okay, so this all depends. And similarly in the tension pneumothorax, so you will, I already written it here, you will go for the auscultation of the lung sounds. Okay, if you find the air entry is not equal, that you can suspect the tension pneumothorax. And also check the trachea with your palpation if you doubt. The tamponade, you will ask the nurse, okay, could you please, yeah, I write all 4H and 4Ts below. So I just stop it there to see what is your reaction. Anyway, so tamponade, you will ask a nurse, could you please do the bedside echocardiogram if you still didn't find what is the result, what is the cause of cardiac arrest. For thrombosis, and it's likely the cause is maybe it's irrelevant, is child, less likely in this case, you can say. Toxin, as I said, the nurse will provide you when you reach to the toxin, maybe nurse will say, doctor, the parents give me this box of medication, and she said the child maybe have taken that one as she's missing some medication. So that can give you idea what could be. And of course in the box will be written is either is adultition or another medication, and then you have to take intervention accordingly. Okay, clear so far? This is the same way you need to run as out of resuscitation, but the difference is in between in APL is that the first is the drug doses, the intervention, that little bit different. For example, the CPR here would be 15:2, but in adult 30:2. Another here is 5 rescue breath, but in the adult you don't have to go for that. So these are very important. I think it's clear so far, right? No any question here, right? Then you have to go for reassess ABCD, and that's it. And then you have to hand over. Any question?
It's clear, sir.
Okay, that's great.
Yes, Dr. Bindi, when to hand over?
As I said, you in cardiac arrest, it would be perfect if you go for reassess. Once you finish these 4H and 4Ts, and if the nurse side, once you finish 4H and 4Ts, then you will ask the nurse, has 2 minutes passed? Look, I have written everything here. You see, has 2 minutes passed? If yes, please check the rhythm on monitor. Then you have to focus on monitor. Of course, the rhythm, if it's going to be fine, then you will find the sinus rhythm, and then you will say, okay, patient has got sinus rhythm. Can you please check the patient has got the pulse? You check by yourself. Remember, I said to always to everyone, please do first, okay? You should do by yourself first. If nurse want to take over, then give her a chance to take over. But first you do, because they want to see you whether you know how to do it. For example, check the rhythm. For example, assess, feel the pulse. You should do it first. Okay, you saw the rhythm is sinus tachy. Now you go by yourself. Okay, I'm going to feel the pulse. Okay, I found the pulse. Okay, that's me. Patient is going to be still. Patient has got the risk. Okay, thank you very much, guys. You have done a great job. Now let's reassess the patient right now. But if you want to give a little brief, okay, we have found the patient most likely to goes in cardiac arrest secondarily to hyperkalemia if you found in the report the blood test, or if it's due to tension pneumothorax, you can verbalize. Let's reassess the patient now. Then we will hand over patient to the relevant specialty. Okay, let's go. What about the patient? Is the patient the airway patent? Okay, good. That's great. What about the oxygen saturation? What about the blood pressure? Then you go further down to the GCS, and also to the temperature, and then I'm going to hand over. So then you have to hand over. If you still have time, then you verbalize to the relevant team. Okay, this patient came up with these following features. We have done this, we did CPR, we give fluids. More likely the patient has this condition due to blah, blah, blah. Hypothermia, due to low blood pressure, due to the tension pneumothorax, or due to the low body temperature, anything like that you have to say. It depends. and then you have to hand over. I think it's written very well, and it's recorded, and you can go for it later. Okay, so our next station, we are going to focus.
Dr. D&D, should we mention post-stroke management?
Yes, if you have a time, but it's not relevant. As I said, in the cardiac arrest, they want to test you two important things, which you keep in your mind. Number one, they want to test you how you run the station. Or you, for example, in the adults, we give 30 to 2 and the CPR, but in children, we give 15 to 2. One is this. The drug doses, they will test you. The important in both station, adult and children, is the 4HN40s to find the cause. Once you haven't found the cause, that means you run this station blindly. You don't know what is the cause of this patient, this condition. This is wrong practice, which you guys are doing, and I'm unfortunately not few of them, but many of them. They usually like start the CPR. Okay, they say to 15 to 2, and then go for the for example, to defibrillator, etc. Till that they are good. But when come up to 4HN40, they just say, I will go for 4HN40s. Okay, what is, has 2 minutes passed? No, you didn't go with the 4HN40s. It's just you said, I will go for 4HN40s. Now in 4HN40s, you will get the blood, you can get the blood result. Here, you maybe need to look at the monitor to check what is the blood pressure. Here is maybe patient is hypovolemic. Maybe you need to give the fluids. You always skip all treatment. All the important intervention, you skip it because you haven't go for 4HN40s one by one. For example, hypovolemia. Okay, I see patient blood pressure. Okay, so less likely. Hypokalemia. Okay, do we have the blood hyperkalemia? Do we have the blood result? Do we have baby sheet, guys? Okay, can you please provide me? The nurse will say, what do you want to know? Okay, could you please help me to check out the patient, the potassium level? Okay, you found it's higher, then you have to take intervention, right? If you don't go for each type, so that means you skip entirely 4HN40s. Of course, you will lose most of your score. I would say 80%, and you will get only 20% because this Alice algorithm, just to go read by, everyone can read it. The next our case would be anaphylaxis. Is very important. So remember a few important things about the previous station. As I said, 4HN40s are very important.
Dr. Bendi, one thing more, only one thing. Should we mention endotracheal intubation between the CPR or not?
Yes, this what you can say, like once you start it's a patient require intubation, please call the anesthetic. You just said one time, you don't need to go for again and again. Okay? That's your job to mention, but overall you will manage with the back wall mask. Okay, let's come up to the for you guys, you will not need to go for the intubation. Okay, anaphylaxis, this is the same station which we already discussed in adult resuscitation. So what you have to do, the same way you have to run. But few things important I want to focus today here. One is that the diagnosis is here, very important. Excuse me. It says like sudden onset of airway and or breathing and or circulation. So if the patient has any of the problem and you suspect anaphylaxis in that case, so you have to go for adrenaline. Okay, I will show you how we go. So the same way you will go for adrenaline as we goes with the adults. Okay, the IM adrenaline first on the anterior lateral middle third of the thigh, can be left or it can be right. And the doses over here, adult greater than 12, the 500 microgram or 0.5 ml, or the 6 to 12 will be 300, and then 150 or all to 100 in some cases. Okay, sham weight. the anaphylaxis, again, the same way I came up in the station and I say, hello, I'm Dr. B. I'm one of the senior doctor here today. May I confirm your name and the level of seniority or the grade, please? And thank you. Then they will introduce yourself. Okay, we have received following pre-alert, a 6-year-old, blah, 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 is coming. Please call the pediatric team as early as possible. And also the RC team, patient may record the admission later. Thank you. And you will go for it. The who will manage the airway? Okay, the nurse A, B, anyway, anyone? Okay, nurse A, please prepare all equipment like suction. If I don't think the suction here really likely records, so you can skip that. You can ask oxygen probe, oxygen, the airway trolley, the difficult airway trolley. Make sure all equipment work properly. Nurse B, please prepare following drugs: the cardiac monitor, BP cuff, resus, and sedative drugs in case, and also CVP line, maybe patient record later on. And the important is the resus drug is adrenaline here. And then you will go, so is the patient arrived? Is the patient here? Okay, patient is here. Doctor, yes. Doctor, nurse maybe it's the doctor. Patient has all the rash all around the body. Okay, doctor, please look at this patient. What's happened? Okay, then you come up to the patient over the head. What you will do first? The first you will ask first, the patient arrives, she will say yes, she will say, yeah, doctor, patient has all around the rash, all around the body, patient is here right now. Okay, the airway patient, yeah, doctor, patient is talking right now, patient talking, okay, that means, okay, if the nurse say, yeah, patient is talking, okay, the airway patient, maybe the nurse will say, no, there is a swollen tongue, maybe in this case, so what you will do, guys? What you will do, guys, if the nurse told you here, the patient has swollen lip and also the tongue.
It's anaphylaxis. We need to give adrenaline by IM. Depends on the age.
Okay, that's correct.
0.3 milligram or 0.15.
Okay, that's good.
So
but
start,
what about the
start
airway?
giving start giving the adrenaline.
First of
Call
all,
the pediatric
we think
anesthesia.
about the airway. Airway can be compromised.
Yeah, that's correct.
So give adrenaline, call pediatric anesthesia as the airway may be compromised.
That's correct, guys. So how you will make the airway patent, guys?
By NPA, nasopharyngeal airway, because the nasopharyngeal airway may be difficult in this case.
Excellent. That's what I want to ask. Want to let you focus on, because you are not going for intubation, right? But the airway should be patent, that you can give the half oxygen to this patient. While doing so, you have to go for nasopharyngeal airway. Meanwhile, you will also need to go for the adrenaline. So you have to verbalize first. I see the patient, the airway is compromised, and I see the patient is all around the rashes. So it's likely patient is anaphylaxis. Please, nurse A, give this patient 500 microgram the adrenaline on the anterior lateral middle of the thigh on the left leg. You have to mention that, and please remind me after 5 minutes. Okay, thank you. Now the airway is patent. You apply the hypofloxacin, and then you will go for the breathing. Please connect the cardiac monitor, or you will ask a nurse, please connect the pulse oximeter probe to the patient and check the oxygen saturation and the respiratory rate for me. Thank you. Then meanwhile, I will go for the lungs, the inspection and palpation of, or I'm going to do in other things in this patient. For example, okay, I'm going for the inspection. You check the rash. Okay, I see is all around the rash here, and also I'm going to palpate the trachea. Okay, I see the trachea central and chest expansion. I see chest expansion. Okay, and percussion. Quickly, you will do by yourself. Okay, done. Now I want to hear the sounds, the lung sounds. Okay, I see it's wheezing still patient. Okay, guys, the patient is still wheezing. The saturation is this, dropping, respiratory rate is this. Okay, is the anesthetic all right? If record here, respiratory rate is low, that means you will go for the connected back wall mask. But if it's okay, then you don't need intervention. But if the oxygen saturation is going to decrease, maybe you will ask the nurse, please call the anesthetic, patient require intubation as soon as possible. Okay, I see the patient still wheezing here, wheezy chest. So, okay, nurse, please. It's has 5 minutes passed. Okay, I see. It's confirmed again. It's the anaphylaxis. Please give the second dose of adrenaline to the right thigh at the level of the anterolateral middle third of the thigh. Thank you. Okay, so you goes with the breathing, and you already going with the 2 doses. While you're going for the 2 doses, maybe you'll ask a nurse, please prepare the IV adrenaline infusion because this is your next stage. So you inform the nurse to do this one. Then you will go for circulation. For example, if the nurse say 5 minutes didn't pass yet, that means you don't need to go for second dose here, even though there is wheezing. Then you go for circulation. Okay? So when you come up to the circulation, and if you found the circulation is compromised, low blood pressure, then you will ask the nurse to give the second dose. But remember, I already written here these types. 1 second, I need to add these people which are waiting in the room. Okay, so once you find here, for example, vital parameters. So as I said in previously, vital parameters you can note from the monitor. Okay, from the monitor. Then about the peripheral pulse or CRT, you can use your 2 fingers, or either check from the sternum or any other level area where you can find easily to check the CRT, which is usually less than 2 seconds. So now here, vital parameters you found, for example, BP is low, patient is tachy, etc. Then you will ask the nurse, please insert the large per cannula, extract the blood for FVC, VBG, but don't forget trip test level, which is very important in this station. Okay. So you will ask the nurse to do that, and then also UNEs, which is not very important, but you can say. And important, another, you will ask a nurse, please take an ECG, provide me strip as soon as possible if you can. Thank you. And then you will verbalize the finding. Okay, I see the patient blood pressure is low. I see this one. So patient already got the first dose of adrenaline. Patient requires second dose of adrenaline. Please give the adrenaline 500 microgram, blah, blah, to which site. If you already given, then you ask the nurse, this patient is in refractory anaphylaxis, and that's very important to need to store the adrenaline infusion. Is the adrenaline infusion is ready? Maybe nurse say not ready. Then you say, okay, please continue give the adrenaline. I am the enteral middle thigh or the for till get ready of the IV infusion of adrenaline. Okay, every 5 minutes. After every 5 minutes. This is in this case when the adrenaline infusion not ready, but if it's ready, then you have to start it. Okay. Meanwhile, I continue my assessment, and also you have to go for the bolus if not given, like 10 ml per kg. Okay. So then you will go for disability, and important thing I want to tell you what happened. The RChem want to test you 2 things here. Number 1, they want to test you. First of all, they want to test you how you manage the anaphylaxis patient. For example, they want to check you what intervention you take. Once you give the second dose of adrenaline, they found that you're good at managing this patient. Then what they will do, maybe they will make this patient in cardiac arrest later on. Okay, so this is what happened in 2 of my colleagues when they give exam. They said it was straightforward station, but when he came to exposure while going for reassessment, the nurse told him the patient is in cardiac arrest now. So in that case, you have to go for the Appellus protocol, okay? Because this is child, so you have to go for Appellus. Okay, so you'll ask the go for the 5 rescue breath and then store the high quality CPO, which would be here 15 to 2. Okay, here is 30, right? Because it's adult. So I want to make it 15 to 2. Okay, then again, you will go for the shock, and here would be the 4-joule asynchronous, okay? And then you will go for 4H and 4D the same way. But I'm sure once you give the shock, once you come up to has 2 minutes passed, then they will say, yeah, patient is okay now, because you cannot manage everything in one time. So usually you need to give only one shock, first shock, and that will make the patient stable after that, because that means you're successful. Remember, guys, once you notice that you are doing correctly, believe me, the nurse will stabilize this patient early, because they already crossed the task. Their task was to test you. How would you manage the anaphylaxis first? And then if the patient goes in cardiac arrest, then how would you manage? What step would you take it? Once they found you're taking correct steps, they will stop it. They will stabilize the patient for you, and then you have to hand over the patient. That's it. So I would say the station all depends on you, how you run the station. If you run the wrong station, believe me, you will stuck all the way, because they haven't reached what they want to test you. But once they reach what they want to test you, they will stabilize the patient for you. That's it. And it could be within 8 minutes you can finish. And even you can have a little more time after that. Okay. So I think it's very clear. Similarly with the adults, but the difference is here again is the dose. That's very important, and you have to take the steps I mentioned here for 1, 2, and these are very important steps in the anaphylaxis. That's it. And reassess the patient, and then you will hand over if you have a time. If you don't have time and you finish, or for example stabilize the patient, that's it, you will get your score. Usually candidate doesn't get 10 out of 10. It's very rare, maybe 1 or 2 station. The most of time people get the station, this score is 8 maximum, most common, I would say, and the very rare to be 9 or 10. So it depends. If you run the station very well, you will get around 9 at least. Okay, so no question here, guys. I think it's one important I forget it. One important thing is, remember that the nurse maybe ask you in the end question. Maybe she can ask you like that. Doctor, you say to give the adrenaline 500 microgram. How? Then you say 1 into 1,000, right? You have to mention that. Maybe they want to check whether you know or not. If you verbalize it early, that would be great. If you forget, then they can ask you in the end. Or in patient in cardiac arrest, regardless of the anaphylaxis, even due to anaphylaxis, but you will go for 1 into 10,000. So remember that. Okay, so so far, guys, any question in this area?
Yes, sir. How do you prepare the adrenaline infusion?
That's the last time I focus on that. Who can tell me how to prepare, guys? 10?
1 milligram of adrenaline, 1 in 1,000 will be diluted in 100 ml of sodium chloride, and the infusion rate will be 0.5 ml to 1 ml per kg per hour.
Yeah, that's correct. So this is how we do, and this is the same in the adults, but the rate could go slower in the children. Anyway, so you can check out that refractory anaphylaxis. But remember one thing, once you give this 2 doses of adrenaline, you must need to verbalize the patient is in refractory anaphylaxis. Okay? Got it, guys? Once you found you have given the 2 doses of adrenaline, the patient condition is not improved, yet to be in the same place. You're finding low blood pressure or the airway compromised. That means first intubation if it's airway is still compromised, and second, you will declare that patient is in a refractory anaphylaxis now. You must need to verbalize, because this is going to be changed a little bit here. So you will verbalize, you will get good score too. Okay, so let's come up to the pediatric arrhythmia. Don't worry, when we will have role play, many things will be clear and you will catch it easily. Okay.
Sorry to bother you, Dr. B. If the airway is compromised and we are not happy, the airway is not patent, should we go for the, and we are unable to pass the ETD, should we go to the front of the neck to pass the cricothoracotomy?
You will never have this situation, believe me. Never.
Okay.
It's not possible they would say you go for ETD. Even you don't have to go for ETD. Remember, you can go, what you can do, you can go for LMA. You can, first of all, you will go for oral OPJ, NPJ. If not, then you'll go LMA, which we say SID, supragalactic airway devices. But you will not go for ETT. Remember, no any station they will ask you to go for ETT. Okay, it will never come up this such kind of things, because for that it's need anesthetic. You need to verbalize that's it. Okay, let's come up to the arrhythmia. Is the same thing like in adults, but the little bit different here is doses and two important things. One is decompensated and decompensated. For the USCI, it's over decompensated, and likely can be SVT, can be VT. Okay, so just remember you need to go.
Sorry, maybe the station is related to airway management. So then
that is a procedural skill. I told you guys. I think I put in the group too. That is about the procedural skill, because in procedural skill they want to test you how you manage the airway, but not in the other station, like not in resuscitation. This station already come what you said, airway management. That station come twice, and I think I mentioned in the WhatsApp too that they want to test you how you measure the size, what devices you use. Okay, but they will test you until LMA. They will not go beyond that.
Yes.
Okay. So let's come up to the arrhythmia here. The most common station for resuscitation, of course, decompensated, compensated. You don't have to. This patient even doesn't require it. So the compensated, the most important is the SVT and VTAC. But it can be bradycardia if you found it, but for that you just need to ask the optimization of the oxygenation. That's it. If it is continuously like that, maybe you will go for the CPR, but I don't think so it would be, and I even don't think so it can really come in exam, but you should know about it. The same like in adults, but the difference here would be the doses, and the first line in this case in SVT is synchronized if no IV access. But very important again, sedation, and analgesia always required if the patient is conscious. If unconscious, you don't. I think you should go with that. It's not really very difficult. The dose is important here is like if you found the SVT, and if there is for example, if there is the IV access, then you will go for adenosine, and the dose is 150. Depends on the age, and then 200 or the below 3 mg IV can go to 6 mg, but it's in adult it's changed like 6, 12. This is how we do now the adult resuscitation. Okay, so the retake is the same similar way. Okay, the synchronize, and I don't think so it's really important to focus on that, and the amiodarone, but amiodarone before third shock. Okay, now let's come up to how to run this station. And remember, these all the SVT, these all arrhythmia station eventually goes to cardiac arrest. They don't want to test you just the arrhythmia, but they will make more likely to make in the patient in the cardiac arrest. Okay, more likely and very common. If this arrhythmia station is there, very common. The stationing, the end will be in cardiac arrest. Okay, same introduction yourself. They get introduction, then you have to run the station, ask them to prepare equipment. As I said, the same way which is relevant. Suction may be required in case of bleeding, but you can skip the suction. Maybe you can ask oxygen, the airway trolley, etc. The cardiac monitor, of course, is very important for the arrhythmia, BP cuff, research and sedative drugs. You have verbalize, and you will go through the next. Is the patient here, conscious, unconscious, conscious, okay, conscious, good. Unconscious, look, listen, feel. You do by yourself. Check it. Is the patient has sign of life? Once you found the patient has sign of life, and that's great. And you have to go for next. Check for the airway. Follow the ABCDE protocol. Is the airway patent? Yes or no? Yes. Okay. If no, head tilt, chin lift maneuver, or in case is not yet, then jaw thrust maneuver. And then you have the airway patent. Okay, that's great. And then you will apply high flow oxygen if required. Okay, so breathing the same way. What do you think? Something I want to give you some tricks that you can get it. Look, guys, in arrhythmia station more likely to be focused on C. Okay, got it, guys. Some station give you a clue what the station need to be focused where. For example, anaphylaxis, right? Anaphylaxis should be focused on airway, should be focused on C. Two important parts, right? But in arrhythmia, the most important where the RChem want to test you is C. Get it, guys? Some station can give you idea where you're going to be tested. For example, arrhythmia, you will be tested in C, likely, because you will know the heart, the strip in there, maybe heart rate you can see on the monitor. Here you can catch it, whether this goes to SVT or VT, or is going brady or tachy. These all things you will know in C. Okay, less likely you will need an intervention in A or in B. So same way, the vital parameters you will note from the monitor. You will look at the monitor. Okay, I see that the patient blood pressure is this. Okay, I see this one. Okay, this patient, the pulse rate is this. Oh, I see also the rhythm. Okay, this looks like SVT. Okay, now I want to check the CRT. You'll use your two finger and check it out from the sternum if you want to check it that way, or which is easier for you to check out. And once you find, okay, then you have to check the intervention, go for intervention. Okay, please the insert two large bore cannula. First you verbalize, okay. Or you can go for the intervention of large bore cannula, VBG, FPG, toxicology screen if required, or UNEs. And as soon as possible, please take the E and ECG provide me. If you cannot get it, you can ask the nurse here. And then, or you can identify the rhythm on the monitor. Then you will have to verbalize, okay, I see the patient blood pressure is low, the strip shows me the SVT, okay, blah, blah, okay, it's likely, the heart rate is very fast, and then you can say it's likely be SVT or VTAC. Then, okay, nurse, please give the patient, if low blood pressure, you can also give the 10 ml per kg normal saline. Okay, and if you found the SVT, and if there is no IV access, then you will ask nurse, okay, please connect touch the defibrillator page. Patient requires shock. As the patient is unconscious, doesn't require any sedation, so please give the first shock is 1 joule per kg. What about the rhythm now? I check on the ECG, the monitor. Okay, it's the same. Okay, give the second shock, please. And eventually you will give third shock and then further intervention. But if you found the patient goes, maybe the nurse say, oh, doctor, patient is unresponding now. Okay, choke, look, listen, feel, no sign of life. Okay, I see, please give fire rescue breath, and then start high call CPR, etc. You have to follow the APLS protocol. So I have written here everything. You just need to go with it 2-3 times and then practice with your friend. Okay, so step 2, you verbalize, and I written here, if the child is bradycardia, you find, and you optimize the oxygenation and with the positive pressure if required. If unconscious less than 60 despite oxygenation, then you have to start chest compression. But if you found if child is conscious and has SVT, then you will go for sedation, but that you have to cool the anesthetic. Is the anesthetic here? Please give the sedation. If not, can I give? Then you should know what drugs can you give, guys? Do you remember conscious sedation? What drugs can you give?
Fentanyl and propofol.
Yeah.
In
pediatrics, we can give the ketamine.
We can give, in pediatrics, we can give all ketamine, midazolam, propofol. We can give these 3 drugs also. With analgesia, fentanyl, we can also give fentanyl.
Yes, of course, you have to give it analgesia that you should have to give, or more likely we commonly use is the midazolam you can give for it.
Yes.
Okay, and then you go for if there is no anesthetic and you ask her, maybe the nurse will ask you what dose could be. That question can come up. Okay, but you should remember if it's not necessarily to anesthetic should be for that. You can give by yourself. If you ask a nurse, can I give this? First, we have to sedate this patient with analgesia. Can I do that? Okay. So what
will be the dose of midazolam here?
The nurse will ask you the same dose as we are using for as usual. The dose of the midazolam and also fentanyl, both are the same. So
I think ketamine is contraindicated below 1 year, right?
0.1 to 0.3 milligram per kg is the midazolam dose.
Yes, it is. What do you say?
But fentanyl 1 microgram per kg.
Yes. Someone asked me a question, a lady. I don't know. What was your question, please?
I was saying that ketamine can't be used below 1 year of age.
Yeah. Why don't we use, guys? Do you know that?
Risk of laryngeal spasm.
Risk of bradycardia?
Yes.
Risk of laryngeal spasm.
Laryngeal spasm, very common in less than 12 months, okay? This is very common, that's why. Okay.
Because it increases the secretions. Because
also,
yes.
Also, there are several things, but what I want to say, the most common drugs, which I just now mentioned, so these are very important drugs we use. So for that, it's not required all the time anesthetic, but if you are obliged, good to go. But sometimes the nurse, if you want to do, maybe nurse will say, yeah, you can do, but she will ask you the dose. That's very important. If she doesn't ask you in here, maybe in the end, she will ask you 2-3 questions. Guys, I want to focus one important thing, that the way we practice is good to go. But sometimes some station nurse would ask you the question. I want to tell you what question could be. In this station, which we are focusing right now, maybe she will ask you the drug doses. Okay, if you missed it, if you didn't verbalize it, maybe she will ask you. If about the CPR, you didn't mention what ratio, maybe she will ask you in the end. Okay, so this question can be raised anytime from the nurse. You should be ready. As in other station, for example, if we talk about the seizing child, maybe nurse can ask you the question in the end, what are the causes the patient is having seizure? So if you found the ratios, low blood pressure, maybe you can check maybe you can consider meningococcal septicemia. If the patient seizure is already stopped in 5 minutes, maybe you can consider febrile seizure. Okay, so maybe she can ask you, talk with the parents, what you will answer. If parents ask you this question, what you will answer to them, maybe 2-3 questions in the end. Similarly, in newborn, maybe the nurse can ask you the question that what is the chest compression, how we give. Then some candidates, of course, they would say 15-2, which is wrong, but actually 3-1. So this question can be raised anytime. Maybe they can also ask you about the adrenaline doses. That's also very important. But first, initially, you have to give 20 microgram per kg. So this question can be raised anytime. So you should be very ready for it. That's why I always say, when you're prepared for the exam, you should prepare from all the corner, that you shouldn't lose your score. Each question, if they ask you 3 questions, I would say almost 6 score came up from these 3 questions. They raise this question because you missed this point. That's why they raise the question. Or they want to test you that what information, how knowledge is yours, how best you are. They want to test you. So question, try to answer correct. Even you run the station a little bit wrong, no any problem. But if they ask you the question, they really, really take it seriously. That's why they ask you a question to test you, and you should give the correct answer. And I believe that you will get a good score if you give the answer correctly. Anyway, I hope I will ask you the question when we practice about role play. Okay, so we take sedation the same unquoted DC shock with a sedation IV and Mudorine before third shock. Okay, so this is how we do. In the end, is about the disability. You'll go for the check the patient level of consciousness, etc., and then you'll go for temperature, etc., and then reassess the patient. But as I said earlier, in arrhythmia, more likely the patient will go in a cardiac arrest, and you have to store the fire rescue breath from fire rescue breath to 15-2 compression. Okay, the same APLS protocol here once in cardiac arrest. Okay, is clear so far? No any question here?
Dr. B, I want to ask one question.
You always ask me one, and you should count how many already you have been asked. Okay.
Okay. In case of pediatric bradyarrhythmia, if respiratory rate is normal and heart rate is low for age, so we should optimize oxygen maybe with the non-rebreather mask, or it is must we should use bag valve mask if even respiratory rate is normal.
We can give the positive pressure. Bag valve mask is respiratory rate is going to be down. In that case, maybe you can go for it, but I don't think so. You will have like this kind of station. No, not really.
And in the same situation, if we have to do the chest compression, so we will do chest compression along with 15:2 ratio.
Yeah, that made 15 compression 2 vents.
Okay, thank you.
Okay, 2 vent, 15 compression. Okay, so now we are in very, very important station is called newborn. It's something fishy and something new, which is a bit complicated and a little bit different. And I believe that you will learn a lot here today. And this is very important station. Always raise a few questions, and it can be confusion as well. Now let's come up to this device. What is this, guys? Ever you seen this device in your hospital?
This is warmer, baby warmer.
Radiant warmer.
The radiant warmer.
Yeah, that is Resuscitaion. Okay, this is very important device if you need to verbalize in your exam. Okay, I will come up to that later. This is what, guys. This is the Apgar score. Okay, you need to go for each point if you want to get a score in newborn. Okay, so let's come up to the newborn resuscitation. I written it here. Everything here is here. If you don't know how to run the station, you just follow it. That's enough. You will pass. I'm guarantee. You will get your score. And I'm sure if you goes very well the same way, it also depends on your fluency and also the communication skills. If you do very well, you even can get a 10. And I don't think so you will have any problem. Okay, the same way, introduce yourself, everything, but you have to go for newborn alert and please call the NIC here. Okay. And the same way, but few things is very important here. The nurse A, please prepare following equipment: neonatal resuscitator, 2 towels, and make sure all equipment should work properly. This is very, very important because you need the 2 towels. And also very important, one more thing which I forget here to write down. Could you please tell me what could be? Anyone can tell me?
Umbilical cord clamp.
No.
The cord clamp has always
you know Yeah, this is not important here. The important
Start the
is
clock. Start the clock.
Radiant
clock.
heat.
Clock.
Clock.
Clock. Yes,
Clock
clock.
is important in newborn.
Radiant heat or the clock is also, you can find a resuscitator also. It's all, everything is there. Okay, no, it's not about the clock. It's about the, look, guys, preterm born. For preterm, you don't need a towel, right? You will wrap in what?
Plastic bag.
Polyethylene sheet. Polyethylene sheet. Okay, polyethylene sheet. This is very important if the preterm. Okay, so I didn't write it, but you need to verbalize. In the case which is written outside on the door, it will be mentioned there. Okay, so you should read the case very carefully. That is a preterm or the term or near term. Okay, you should be very careful. If not mentioned, you can ask inside in this stage. Okay, I have written inside, and you can check it out. Okay, so make sure the all equipment should work properly. Resuscitator is very important, guys. If you cannot pronounce that, you can say to radiant heat also. Okay, no problem. And the nurse be cardiac monitor is the drug, it's IV fluids. If you say that's good. And then is the newborn here, is a baby arrive. Okay, that's great. Start the timer. Look, I have written the steps here. Start the timer, and know the time of the birth. Short history, you should take it if you don't know. If you know, then skip. Near-term baby or the preterm. If found, then aim to a 1 minute delay cord clamping, or you can, but I would say for the purpose exam, just clamp the cord. It's okay. Because in that case, you need to bring baby anyhow on the resuscitator. If you don't clamp the cord, how you can bring it, right? So for the purpose of this exam, I would say clamp the cord and bring the baby to resuscitator and place under the radiant heater. Okay, and dry the baby if it's a term. Okay, you will ask a nurse, please dry the baby with the warm towel, with the dry the baby with the towel, and again, then wrap it with another towel. Thank you. Okay. And then if it's a preterm, please put the baby in the polyethylene sheet, but don't cover the face. It should be visible out. Okay, so it should be, and it should be uncovered. Okay, the step 2, then you will say, I'm going forward to now assess the outgrowth score. Is I'm going to stimulate the baby. Do you know how to stimulate the baby, guys? Maybe you need to do it. You don't need to wait for the nurse. Maybe you just pick up the baby, okay, and do it by yourself.
Just little rub on, rubbing on the back of the baby.
Look, guys, I want to tell you, everyone, the step all written there, you need to follow, but you need to skip few things which you already know it. For example, if you know this a term, then you don't need to verbalize everything, right? You just skip, okay? So this all step, the way I written here, you just follow it. That's it. But you need to practice few times. Now I'm going to stimulate the baby. You will just say, now I'm going to stimulate the baby. Okay, you just show your hand and rub on the back, and you will say if the patient can, or from the sole of their feet you can do. But nurse will see that you are doing, right? That's it. They want to see what you're doing. That's it. And then you will say, now I'm going to assess the tone and color. Here, nurse will say, for example, the baby is sinused on peripheral, on his lips, or etc. She will say like that. Okay, the baby, maybe she will say, okay, baby is pale, flappy. That, right? She will say like that. Okay. And then you will go for heart rate, and you will use your stethoscope to check out. Okay, do you feel that? And you just guess it. Nurse will say, oh, heart rate is low. She will say like that. Okay. But if not, you already didn't bring the baby to resuscitate, now you can bring up, and no problem. Otherwise, you skip. Breathing here, I'm going to assess the breathing of the baby. Okay, I see. Just try to assess. Okay, I see. And the nurse will verbalize, oh, baby is gasping. Baby is, for example, there is absence of breathing. Now, after doing these all 4 points, which is important here, then you need to take out the outgrowth score. You need to calculate by yourself. And now you will say, okay, I see the baby score, outgrowth score 6, for example. So then quickly, okay, baby require urgent intervention. Please keep the neutral position on this baby. Open the airway. Airway is open. Now I want to, for example, use a saturation probe and also connect the monitor, etc. And then you say, okay, now I'm going to give the 5 inflation breath. And now I want to assess the response. Like I want to see the chest movements. Is there chest movements after 5 inflation breath? No chest rise. Okay. Then you will see again try to adjust the face mask with jaw thrust and ensure the head in neutral position. Good seal. Then again try, for example, or you can directly go to 2% technique. Now I'm going to do a 2% technique. Okay, what about now? I give the 5 inflation breath. How about now? Is the chest expansion now? Yes or no? The nurse will say no. If yes, that's great. Okay, then if yes, of course, probably they will say yes because they want to test you skills, how you go for it. And then you will go for ventilation breath once you find there is expansion in chest. And you will go for 30 breaths per minute. Okay, this way you can go for it. Is the same thing which is written in the research council. But here I write in the steps that it is easier for you to just verbalize and you move forward. Okay, so then after ventilation breath, we will come back. Okay, we will come back to it. I will give you a chance to ask any question. Okay, you want to ask me a question, right?
No, go ahead. Sorry.
All right. Okay, so ventilation breath. Once you finish and you see that is there no response, you will go for chest compression. 3 to 1, okay, 3 to 1, you will go for it. And then if it's still no response, every 30 seconds, you will go for vascular access. And then you will go for the fluids and also the drugs, which is here. More commonly, we use adrenaline, 20 microgram per kg, or in 0.2 ml per kg intravenous, or yeah, you can go for it, or in case needs dextrose, you can also go for that. Eventually, patient will be stabilized. In the end, the last stage, usually the twice resuscitation has came, and both time it was in the end, and they said patient is stabilized once they give the drugs. Okay, so what is your question, please?
Sorry, I was not clear about. First, we have to give the 5 inflation breath. Then, if there is a no chest rise and the heart rate not increase, then we repeat the second inflation breath of the 5 sets. Then, if these are the 5 inflation breath on the ambu bag or in the atmosphere air, we have to connect the oxygen or not.
Your question is about the 5 inflation breath, right?
Yes.
I will answer this question.
Yes.
No problem. Actually, this is with oxygen, and you have to use big valve ventilation.
Okay, you have to give the 5 inflation breath with the ambu bag attached with the oxygen.
Yes.
At the term.
Yes, because patient is cyanosed. Without oxygen, there is no advantage.
Okay. After the 2 sets of the 5 inflation breath, if the chest is still not rising, and we have to continue the 5 inflation breath for another 30 seconds, is it again attached with the oxygen or not?
Actually, we have to reassess both things. We have to assess the patient's heart rate and chest rise.
It's clear. The thing I am not clear is when we give the 5 inflation breath, first set and then the second set, the initial 2 sets, either this is the atmospheric air, and the third step, when we continue the ventilation, the third step of the inflation breaths, should we continue it with the oxygen or without the oxygen? My question.
With the oxygen, but in third step, if heart rate is less than 60 and there is no chest rise, so you have to start CPR actually.
No. After the 2 inflation breath, either the heart rate is present or not. We have to continue the ventilation for 30 seconds. Is it clear? Dr.
Okay.
P, please answer this question.
Hello, actually, I will give you answer of this one. First, you have
Okay.
to give 5 inflation for
Yeah.
1% technique. For second, 2% technique, 5 inflation. They
Clear.
definitely tell you the now is chest rise. They will not test you again and again. They 2 times
My
test
dear-
you, and after that, 30 ventilation for 30 seconds. For each ventilation for 1 second, for 30 seconds, you have to give for. If there is no heart rate, they will ask you. You will ask them heart rate how much. If they're less than 100, you have to give this one.
You are correct.
For,
You are correct. My question is not. My question is, we are giving
With
the 5
oxygen.
inflation breath. Either we give it with the oxygen or not. My question is this.
Yes, definitely. We have
With-
to give with oxygen. We have to give with oxygen.
Thank you.
Sorry, if you look at the algorithm, the first inflation breath that you give is on air, is without oxygen.
Yes.
And in fact, you don't get to use oxygen until probably when you are doing the CPR. Because in the first 10 minutes of life, the preductal oxygen level of the child should be around 90. So you are not really expected to bring in oxygen at that early stage in neonatal resuscitation.
Excellent.
Up until when you start. So by the time you are starting chest compression, you're already saying, can you please attach probe for oxygen monitoring? That's when it becomes significant. So it's until then that oxygen can start coming in. But the initial inflation breaths, if after the first inflation breath, there's no significant response, the second inflation breath, you make adjustments in terms of, do you need to suction the airway? Do you need to reposition the head? Do you need to increase the pressure of the inflation breath? If you are starting with 25 cm of water before, you can increase to 30. So
Thank
those
you,
are the
doctor.
initial things.
Thank you, doctor. You have clarified. So all the people are at the same page. The first 2 sets of the 5 inflation breath, we give it at the atmospheric air. We will not connect it with the oxygen. It is clear so far with all the students?
Yes, okay. Yes.
Yes. Because this is very tricky. I want to make clear from Dr. B.
I have very carefully to listen everyone. Everyone try to answer. I'm very surprised, to be honest.
Yes, sir.
That's really surprised. So look at this, the algorithm we have it right now. Look at this one, and now you can read it by yourself one time.
Yes, sir.
Okay.
Yes.
Did you see that? So
yes, sir. 5 inflation breath, start in air.
Start in air. That's correct.
Yes.
Anyway, the what they want to test you in newborn resuscitation, once you come up to the chest expansion, for example, they want to see you say, excuse me, yeah, this one. Now you could focus on this fine inflation breath. They actually want to see this, is the chest is expand or not? What could be the cause if not expand?
It means
is not properly open.
It means there is either this is a high there is a congenital hernia, or there is a congenital heart disease, or there may be a intention pneumothorax, that is the barotrauma.
That is why they want to give fine inflation both to check out that one.
Yeah.
Okay, so it's not necessarily you give with the oxygen or in the air. It's not a big deal about it. They just want to give to make sure that chest is moving or not. Their focus on here is chest expansion. Okay. If it's not successful, then go for the oxygenation. Okay, let's come up to the ventilation breath. Once you found expansion, then go for the ventilation breath. 30 per minute, lasts around 1 second. Okay, and then you go for the, if not successful, you go for chest compression. But this all depends on the, do you see that this all depends on the heart rate again? As long the heart rate is low, you will go for further intervention. For example, here you will start the CPR, which is 3-in-1, okay? And then you will go for the, again, to reassess for every 30 seconds. If there is no response, then you will go for umbilical vein you will go for the drug, the adrenaline, or the fluid. Okay. So the overall conclusion, newborn, the testing is what equipment do you use it? And now, can you tell me one more important thing? What is unique in newborn, guys? What is unique?
The head is large, so the neutral position is important. We have to put the towel in between the shoulder blades.
I am talking about this station. What is unique to run this station? Did you follow the ABCD in primary assessment, guys?
Oh, yes. Because in initial, what is the APGAR score? It is ABC.
Yes, it is APGAR, but not entirely the way we run the station. This is not very like, you don't come like the baby come up, okay, could you please check airway, is the airway patent? You will run this station like that way? No. You're running the station wrong. This is what I want to focus. This is totally unique station.
In the unit will be B first, BACD, or sorry, C circulation.
If we go very deep, we will go very complex. Just I want to say that this station is unique. You don't need to run like ABCDE. Okay. Just keep in your mind how you run it. Just follow the algorithm. This is very important here. Nothing more is important here. Only the algorithm. You get it. You take the initial steps, like start the clock. This is very important point. You run into this station, then change it. You will not go for the baby brought in the ED and you will ask nurse, is the airway patent? What do you think? Then what she will answer to you. No, you don't need to run the station that way. This is the unique station. You will not run as other station you're running. There are a few more I will focus on later on it. Okay, so far it's clear, guys, this newborn, right?
Yes, sir.
Yeah, just remember chest expansion is very important. Second is heart rate. These 2 points are important in when you run the scenario. But the other things like the stop clock, the start the clock, the put on the radiant, and also the usage of the equipment, for example, the other stuff like the towel for the term, and for preaching we use polyethylene suit. These are another thing, and also sometimes we need a suction, but it's not very important. Overall, chest expansion, you get it. You go for ventilation, you get it. If not not successful, no change, go for chest compression, then umbilical vein. The drugs, that's it. You're all done. And they will stabilize the child, the newborn, and then you reassess. When you come and reassess, guys, then you will go for ABCDE. Okay? So in a primary intervention, you don't need ABCDE, but in reassessment, you will need it. Then once you finish the station, maybe the nurse will ask you, doctor, how many compression do we need to give? Then you will say 3 to 1. And then maybe she will ask you about the drugs. If you didn't mention, they want to test you. So in that case, they will ask you. But if it's still after CPR, if you found things are not improving, for example, then maybe you will consider tension pneumothorax in this case, like Forage and Fortes, but it's less likely you will have it. So this station is very important and very, very common in London DICE. I didn't heard in previous DICE, this is CAM, but I think it's very common in London DICE and likely to come. Okay, thank you for this, for your discussion. You all guys put your hand everywhere, and I think it's very good. And it was a very good question. I think it's clear to everyone too. Okay, so the next we are going to have the seizing child, and seizing child is also a very important station. I think previous diet we had it, right? Who has a previous diet, guys? Anyone? I think they are having rest now. Okay, so there was a few doctors who said they have a question about the seizing child, but the station came in 2 different ways. Anyway, so the same way ABCD follow the check the blood glucose level, the first line drugs, the benzodiazepine evolve in 5 minutes. Okay, after 5 minutes started. Okay, from 10 to 15 minutes. So you could see an algorithm from 0 to 5, there is nothing to intervention, right? Do you see, guys?
Yes, sir. Yes, sir.
Yeah, 0 to 5, no intervention. For example, I will come up to that one. I will show you. So 0 to 5, no intervention. 5 minutes gone, then intervention. First line, 10 to 15 minutes. Second line, 15 to 35 is also 10 to 15 still goes there. 15 to 35, and second line, the phenytoin and levetiracetam, and also the phenobarbital. Then 20 to 30 minutes, and the third line agents. Okay, so this one. I had discussed already. I said already that it depends on the station can be present to you in 2 ways. The first way is could be like once you introduce yourself, everything goes very well, and when you ask about the nurse, is the airway, is the patient here, is the patient alert, is the patient conscious? She say yes, and then you will ask maybe maybe the nurse will say, yeah, the patient is the conscious patient is seizing now, and then you will ask about since how long the patient is seizing. This is something different, which is unique if you compare with the other station. Then she will say, you will ask a question, since how long the patient is seizing. If she says from last 1 minute, then you don't need an intervention, right? You just move ahead. Okay. Next way to go, for example, the airway patent. Okay, if she said the patient is tongue bitten or anything, then you insert the nasopharyngeal airway and apply hypooxygen if required. Okay, then you continue for this one. If the station come up like this way, in the case they mentioned patient was seizing before, that means before, when you come inside in the station, is the patient conscious? She say, yeah, conscious, or maybe she unconscious. Look, listen, feels their sign of life. That means there is sign of life. And then you will go for the airway is patent. If in this case, if she said the airway is not patent, so what would be your intervention, guys?
NPA, nasopharyngeal airway. We will not pass the OPA.
No, patient is not seizing now. Patient was seizing.
Go assess breathing. Open the airway and then go and assess breathing.
High flow.
Okay.
Check for signs of life.
Yeah, there is sign of life, but airway is not patent. Airway is not patent.
We will put the patient on the lateral position.
If airway is not patent, head tilting maneuver.
Okay, if it still is not patent, what you will do?
We have to pass only.
Then we will use the adjunct and we will do the ambu bagging.
We will check signs of life.
Nasopharyngeal airway. We'll put on
nasopharyngeal airway only.
Yes,
guys.
If he is conscious or semi-conscious, then we will apply nasopharyngeal airway. If a patient is unconscious, then we will apply oropharyngeal airway.
That's correct. Now listen to me. Listen to me carefully. Guys, I give you 2 kind of cases. First, I said the patient is seizing. When patient is seizing, go for nasopharyngeal airway. Okay, if patient is seizing, airway is not patent, you go for head chill. If the nurse told you the tongue beating, patient is beating himself, that case you will go for nasopharyngeal airway. Okay, but if the case is mentioned patient was seizing before, But now in the case you come inside the station, you ask a nurse say, patient is unconscious. Just say unconscious. She didn't say. And you read in the case, patient was seizing. That means patient is not seizing now, right? Then you will ask the nurse, is the airway patent? She said, not patent. Then we will go for head tilt, okay? If you go a job test maneuver. If it's still not patent, then go for OPG. If it's unconscious. All right. This is how we follow, because this patient is not seizing now. If patient is seizing, then NPG. I think it's clear to everyone right now.
Yes.
Okay, you have written there, airway is patent now. Follow the head tilt and chin lift. If the airway is patent now, no. If the patient is still seizing, yes, please insert the nasopharyngeal airway. Yes.
No, I'm not.
Excellent.
Yeah.
Yes, sir.
Yeah, I'm talking about, this is here written, but I'm talking about just ask your questions, test you. There's two kind of cases you can have. If patient seizing, your intervention a little bit modify in A. But if patient is not seizing, your intervention may be a little modify in that case according to the case. Not all the time NPG, NPG, that you will lose your score. Okay. So once we got it, okay. Yes.
Yes, but it's better to insert MBG because this patient, it could happen seizure again, right?
If we go for prediction, then many things can come in our mind. Okay. In that, you know, they made special these cases for you like that to intervene in that at the moment. Don't predict the future. Okay. So the you need to check it out. Is relevant towards. So you don't need to predict. If you predict, there will be many things. Please close the, I don't know which doctor is opening this one. Please close your, thank you. Okay, so let's come up to breathing. Then the same way as usual, connect to the probe or connect to the monitor, etc. Intervention, oxygenation, etc. Okay, circulation the same way. But one thing I want to focus, for example, now, when you ask the baby is here, baby arrived, the child arrived, yes, patient is here, airway patent, airway is not patent, the patient is tongue bitten, you insert the nasopharyngeal airway. But a few things, what would you ask before that? Before, for example, I'm sorry, apologize. I want to ask another question. Yeah, my question is here, patient is arrived and patient is unconscious. And but when you ask a patient is alert, I said, okay, patient is seizing now. And once you confirm me that since how long the patient is seizing, I said you from last 5 minutes. So what would be your intervention, guys? What you will ask, what would be your next question and your intervention?
We have to repeat. Midazolam.
Yeah, before.
Any medicine given by the ambulance crew or no?
Great.
If not given, then we will give the buccal midazolam.
One, this is question. Second question. Is there IV access?
Is anything is anything given? Is any medication given?
Yeah, no, is any medication? Is there IV access? Yeah, because if the medication is not given and there is no IV access, you will go from buccal metazolum or the diazepam.
Yeah.
But if they say it's yes, diazepam is given, right? Or they say buccal metazolum given and patient has IV access, then you will go for lorazepam. So this also little things make sense. You know, you need to run the station totally correctly because you can lose your score. So you need to very careful. Look, this station also a little bit unique if you compare with other. Here you ask everything before you. Here you can even intervene before airway. right? Here you are going to intervention before airway because you have to stop a seizure, right? So this is also a kind of, if you compare with other, is another unique station. For example, the patient is seizing, and now you ask, since how long the patient is seizing? Is there any medication is given? Not given? Is there IVX? No. Go for it. Boom. Go for benzodiazepine if not given, and if there is no IV access, then go for the midazolam or BR diazepam. But if they say it's given, then you have to wait for it, and then go for the next airway, about the airway, and then you go for airway B, breathing. So most of cases, they always depends on the intervention and depends on the step you're taking. So it's in seizure, it's very important before airway. Anyway, so once you come up to date, you go for inspection, palpation. As I say, this station also indicate there will be not really any problem in C, but can be a problem if the patient is having seizure due to sepsis, meningococcal septicemia. Okay, so how? Let's come up to that one, and I want to enforce one important things. Okay, keep in your mind this station is very complex and very important. Now you go for A and you come up to B. B is gone. Now you are in C. You check the vital parameters. You found low blood pressure, tachycardia. The CRT is the elevated. It's greater than 2. And now, what do you think? What would be your intervention? Like you went for VBG, blood culture, toxicology. What
Blood
would you do
first.
next?
Blood glucose first.
No, we are in C. We are not in D. Okay.
Sepsis bundle.
We maintain if there is a IV line, IV line, we will give IV fluid. If there is no IV, if there is an IV line, then we send the all investigation and give the IV fluid.
If you guys remember the adult resuscitation and sepsis, what I said, you guys, in C, your focus should be the volume, blood volume. Focus on only one thing, how to improve the hypovolemia. Okay, how to correct it. Your focus shouldn't be like antibiotics here. Your focus shouldn't be on that. Never. C is relevant to circulation. You need to focus only on circulation. Okay, now I come on to this important point. I want to focus you how you run this station, and it makes sense, and it really makes sense if you follow that. For example, the child was seizing for a long time, and you give benzodiazepine. You go for B, and you confirm how about the child is still seizing, no seizing. If seizing, you will go for second line. Okay, this is another thing which is going on. Okay, you're running that. Okay, now come up to this C. You insert to lower bowel cannula, you extract blood, toxicology screen, the blood culture. This is very important. But what more important point here would be, guys? Other than toxicology screen is not very important here, but what is another important?
Lactate.
Lactate. That's lactate level. Okay. Here you will ask the lactate level. Okay, this is very important.
Lactate and inflammatory markers.
Okay, CRP. Okay, CRP. So you will ask the CRP here. And then you ask a nurse as soon as possible to provide me ECG strip. Then you will verbalize the finding. What you will verbalize the finding, like, okay, it is 6 years old or 7 years, for example, 12-year-old. This child is brought into ED, and I see the patient blood pressure is seizing. Patient blood pressure is this, blah, blah, blah. Please give this patient the normal saline, the bolus 10 ml per kg. Okay, if required further, give it later on. Thank you. Now, meanwhile, I'm continuing my assessment. Okay, then you will go for assessment. Now you come up to blood glucose level here. You will ask a nurse, could you please check the blood sugar level for this patient for me? Thank you. Meanwhile, I go for the check level level of consciousness of this patient. Then the nurse will say, then you will go for, maybe nurse will say, okay, is responding only to pain. Maybe she will say you like that. And then you will go for a pupil light reflex by yourself. Until then, nurse will check the blood pressure and you will ask her, okay, could you please tell me what is the blood sugar level now? She will say, for example, 4. If 4, that means okay. If low, then you will have to give. And that will give you idea here. If the blood sugar level is correct, that means the hypoglycemia is not the cause of seizure, maybe another cause. Then you will come up to E. Here you will ask the nurse, please expose the patient completely. Okay, then you will go for swelling, check the rash. Okay, and you will ask the nurse, could you please help me to check the temperature of patient? And here nurse will check the temperature. And she will say temperature, for example, 38. Wow, more than 38. And you found the patient is febrile. And you found the hypertensive in seizing. What you will suspect, guys?
Septicemia.
But you just suspect. You still not think about it. Then you will verbalize the finding. Okay, guys, we team, or the guys, you can say, we have found this 6 years old is brought-in seizing. His temperature is this. Do we have the blood reports? Do we have blood culture level? Maybe the nurse will give you the culture level. Maybe the lactate level. You will ask the lactate level. Maybe nurse will tell you, okay, this is, and that's confirmed. Likely the patient is having this features is due to meningitis. If you also find this rash, then you will say the meningococcal septicemia. Okay, this could help you. But in case patient seizing stop, in 5 minutes is no more seizing, then in these temperatures very high, okay, and there's no rash, no any other abnormality you find, then you maybe suspect the child maybe have an infection, where you're waiting for the blood results, or if lactate level confirmed, then you again say patient is sepsis or septic shock due to an infection is ongoing, can be CNS, can be another. You can give the diagnosis, suspect.
But it can be febrile seizures.
Yes, but a patient is febrile because of what? Because of something, right? There must be going on. That could be the case. And this is what I said. If the seizure stop within 5 minutes, okay, that's likely to be febrile seizure. Okay, but remember one thing. As I run this station, you have to run the station the way I said you, because it will help you to rule out the other causes. For example, if the lactate level confirmed here, that means patient in septic shock. This is patient in sepsis, right? Okay, so you can give the diagnosis. Maybe patient is going to have, you can just verbalize patient is having CNS infection, and due to that, he's in septic shock, likely is lactate is elevated. So here I'm going to prescribe what? What you will prescribe here, guys? Once you find the patient in sepsis.
Ceftriaxone, 80 milligrams.
Ceftriaxone. And
right.
But in pedia we use cefotaxime, no?
Ceftriaxone. Yeah, that's correct. So ceftriaxone you can also verbalize, no problem. So what I want to say, the antibiotics come here. Okay, the things which is relevant to that, for example, circulation, the antibiotic is not relevant because you're not sure that the patient really have the sepsis. But once you got the lactate level high, some blood test, and also you find the high temperature, this confirms that patient is in sepsis. That's why you give the antibiotics. Otherwise, you're running the station blindly and all the prediction, and it can be goes wrong. That's why what I say, you should follow the steps which really makes sense. Do not give the antibiotics and say, okay, if you don't find, even though if the patient has, for example, okay, I'm going to add another case here for you guys. If, for example, patient has a chest infection, okay, and you find the crackles, what would be your intervention in B? Anyone can tell me what would be your intervention in B?
Can you please repeat the question?
This is, I'm talking of seizing child. I'm talking about, now I'm going to give you another case.
It could be aspiration. It could be aspiration.
Yeah, but how would you know this? It could be aspiration. What you will do?
On auscultation.
One is auscultation. Another intervention. Auscultation you always do. Another intervention apart from auscultation.
Chest X-ray. Yes.
Chest X-ray.
Yes.
Ask for chest X-ray.
Yes. Order chest X-ray in B.
Oh,
don't
excellent.
go for C.
Excellent.
Order chest X-ray in B. Also, you ask the nurse to do ABG in B. The relevant things do in the relevant place. Don't leave for the next step. That you guys are doing wrong. That means you're running the station blindly. Now that it doesn't make sense. For example, you find the crackles in B and you want to do an X-ray in C. Does that make sense? It's not make sense, right?
No. So
it doesn't make sense.
So our goal is EIA. Evaluation, identification, and intervention.
Yeah.
Evaluate, then identify, then intervene.
Yes. The relevant place you have to take the intervention. It doesn't matter where you're in B, you're in A. For example, now airway is not patent, and you're moving to the B. Wouldn't make sense, right? You need intervention in A. First you do clear the airway, then you go for the B, right? The same you can do in B and C and also in D. Now someone say to ask to check the glucose level in C. Doesn't make sense.
Yeah.
Glucose level have own space in D. So we have to go for D. And the for example, if we talk about temperature, we don't have to do in C, but we have to go in E. And once we find all finding and then some of the finding joined together, and then give the suspicion of diagnosis, provisional. Once you find a provisional, I'm great. You will be grateful. You will be happy. Your team will be happy. I am guaranteed the RCM will be grateful once you do that. And this is how people do. Don't run the station blindly, guys. Okay, always be careful. Okay, I think it's clear so far. So in seizing child, you don't need to worry about what you can just verbalize even the CNS infection. That's it. Okay, and make sure that if the seizure stop in 5 minutes within, so you can verbalize in the end is as I write after exposure. Okay, patient likely have seizure due to the febrile seizure due to any infection ongoing and with the child. Okay, and it's recorded like I am going to prescribe paracetamol for that. Okay, to avoid that, and I will give the leaflet to parents and then reassess the patient or the handover to relevant specialist. Okay, so this was about the seizing child, and I said you guys the septic shock can go the same way. Okay, follow the same approach, but the difference is that septic shock cannot be present only in CNS. It can be present, patient can come up in the diarrhea and vomiting, not only in one case, but eventually the station will run the same as it is, but there will be no seizing. Okay. So now let's come up to the recess in neonatal duct dependent circulation. And this is also a very good station and very important too. So let's going to focus on the same way we do. Is the patient here? Okay, arrive. Okay. Usually patient always come up unconscious. Okay, not conscious. Usually, as I know about this case, it's come unconscious, and there is sign of life. Okay, then you will go for airway. Follow the same approach. Hypoxygen you will give, because this you have to give if the airway patent. Then you will go for the connect monitor, probe, saturation, etc. You will go but high flow oxygen, maybe patient oxygen improve or maybe not improve, even though you go for it. But overall, they show normal. Okay. See, if recorded, for example, not improving, you can call anesthetic patient, may require ETT, but it won't help, okay? But in breathing, one thing very important, for example, when you hear the lungs and the heart sounds, but this is very important here is, I would say here, don't go for the heart sounds, okay? This station depends on C. Everything come up on C. In B, you will not have too much problem. So I want to remove the heart sounds, but I want to advise you the heart sounds you should mention here in C. I will tell you how you could go. For example, you say expose the chest and do inspection, you did palpation, you did auscultation of the lung sounds, and there's all clear. There's no any problem. Okay. Then you will go for the C. When you come up to the C, you check the blood pressure, heart rate, and here you will say, now I'm going to auscultate the heart sounds. Okay, I would say better in C, but you can do also in B, no problem. Better in C because it's relevant. When you heard sound check and you said, I had found, the nurse will say there is a murmur on the auscultation. Okay, and you came up in circulation, you check the blood pressure, now you're going for the peripheral pulse. And what you will find in quietation of aorta, guys, what will be?
Brachial pulses will be present and femoral pulses will be absent.
Yeah, that's give you an idea. That's what I said to you. When you will do that, the nurse will say this is the following the pulse is absent, and then you can get a little bit idea what is real cause. And then again, the same way you will go for the and also, as I said, you will do auscultate the heart. You found the murmur, but this femoral delay, the absence pulse will help you, and that's really important point for the coarctation of aorta, and that makes sense. And you will suspect, but what you will say, please insert to large bore cannula, everything, you will go for it the same way ECG, but what's important, another thing, you will also ask the nurse, please get me chest x-ray and echocardiogram as soon as possible. That's very important. Maybe nurse have the chest x-ray and you can get it in chest x-ray. Some point can be bootstrap, can be the synomen. Okay, this can be, you can get idea. Or nurse will give you echo, but you just verbalize that. Of aorta because it's chem choice. But I mean, the early stages is most common is 40s, cyanotic heart disease. I think it's the coarctation of aorta is not there, but patient present to you is shock.
5 Ts, Dr. B. 5 Ts.
Yeah, five Ts. Yes, 5 Ts.
Yes, truncus transposition of great vessels, tricuspid atresia, antitrilogy of Wallet, and there is total anomaly pulmonary venous drainage.
Yeah. Yes.
This 5 Ts.
Yeah. Okay, 5 Ts. Okay, so coarctation of aorta, I don't think so is there, but I want to focus this station came up. Maybe you can have, but I want to give you an idea that maybe you can find the delay in femoral. So that would be the coarctation of aorta. Another important thing, maybe in when you come up to the E, okay, I mean in D, when you check the level of consciousness, they will say the floppy responsive to the only pain one is another finding. Another finding would be could be here in when you expose the patient, the nurse would tell the patient the child is pale, okay, cyanose, and that can also give you idea that this is the congenital heart anomaly. But I mean, if in case you are not sure is coarctation of aorta or another cyanotic heart disease, but as I said, the 5 Ts, the early indication, the early presentation, so you can think about that. The finding you can present like that. Okay, this 4 days old, the child is 4 days old, and there is absent femoral pulse, and this is pale, and he's in shock. It's likely patient is having coarctation of aorta, is a congenital heart defect. Or you can say, according to the age of the patient and the finding which I found on this patient, for example, pale and is in shock, and it could be like congenital heart defect. So what is the intervention most commonly, guys, in most of time we do? What you will do after you go for exposure, as I said in a previous slide, that, for example, you will prescribe antibiotic there, but what you will prescribe here?
Prostaglandin.
Yeah, prostaglandin infusion, you have to start it. So you will ask the nurse, please store the prostaglandin infusion for this patient and keep the doctor's orders to survive this, for survival of this patient. So you just verbalize, and then you will ask about the handover. If you have still good time, then you go to reassess the patient. Overall, it's a very simple station. It's not really complex, but few things to check out. For example, to catch the diagnosis, as I know, they will not mention that the patient is having congenital heart defect. They will just give you a scenario 4 days old. He's present with blah finding, and then you will go inside in the station. You have to find the murmur sound will help you. Okay, number one. Number two, the number one would be age. Okay, age is very important factors for the congenital heart defect. Age. Number two will be murmur. Number three, in E finding, which is present to you, is a pale or the sinused. Okay, she will verbalize to you, and that gave you an idea the patient likely have congenital heart defect. And then you just verbalize and go for the prostaglandin prescription in after E, and then go for reassessment and hand over to patient the pediatrician. That's it. I think got it. No any question?
Sorry, just to clarify, do you still continue the moment we detect that there's a doctor-dependent congenital heart disease? Should we reduce the high flow oxygen that the child is on? To
actually, the high flow oxygen will not really helpful, but we have to all the time to give this patient. Okay. Because there is a mixing between the deoxygenated and oxygenated blood. That's why it's there is no problem with the lungs. Actually, there is a problem with the heart. So, yeah, the overall is not really improving, but we have to go for it. This was your question, right?
No, because I think there is a place of if you over-oxygenate them, you can close the duct. And the moment you close the duct, you make their condition worse because they need the duct to be open. And that's why you're also giving them prostaglandin to keep the duct open so that they can use the collateral circulation because of their coarctation of their aorta. But once you give them high flow oxygen, it kind of like help the duct to close. And with that, you kind of like make their situation worse. So I don't know, but what I used to know is that the moment you detect that there's a duct-dependent lesion, then you should titrate their oxygen to maintain their SAT around 75 to 85 and do other things. I don't know if maybe I'm getting it wrong.
No, it's not like that. You're right that if you give the half-flow oxygen to close the ducts, but is not all the time to the case. It depends on the lesion how far it is goes. Otherwise, it should be closed when the baby is going to breathe, right? So it can be closed. Normally, it's usually closed, and this defect is very large, and it cannot be compensated with the oxygen. Any question?
Thank you.
Okay, so there was someone who asked a question. I don't want to say something. Okay. So let's come up to the important station is the croup and epiglottis is a very, very important station, and the croup is very common, is uncommon, the bacterial cause. So we are going for that. How to catch this one is the station will goes to croup, or is the station will goes to the bacterial infection. This is how we, the age is very important factor again, the under 2 years. What is opposite to the prostaglandin, guys, in case we want to close it?
Indomethacin.
Endomethacin, that's correct.
Yes.
Endomethacin, yeah. Endomethacin is the opposite we have to give and then close it. But it's okay. So in the exam, you don't need to think like don't want to give the oxygen because you don't know it, right? When you arrive in a C, you notify, yes, that's correct, that the oxygenation should be maintained not at 98 or 92%, but 85 or about 82%. So this is how we want to keep it. But you never know because you have to run the resuscitation. Without that, you cannot run it. And if you keep it going that way, yes, in B, of course, you will know what is the saturation. That makes sense. But it's better to go for oxygenation. But I didn't find anywhere like you don't give the oxygen, especially in resuscitation when patient is already in shock. You have to go for it. Okay, the croup is the stridor is very common, which is harsh, and in the bacterial is usually likely absence. So number one, first how to case the diagnosis. When the child come up to you in the ED, and when you ask, is the patient here? Yeah, patient is here. Okay, is the patient conscious? Patient is alert. Okay, the airway patent. Then she will tell you a patient is having the stridors or anything like that. She will mention from beginning, even though. And if you see the age is more under 2, that's likely to goes to croup. But if she say there's nothing, then you both put in your. However, it's very uncommon, the bacterial cause. So you have to rule out is vaccine is already there. For the purpose of exam, I would likely to more focus on croup. That's very common. But another important thing, if talk about the bacterial cause, what intervention is very important, guys, in bacterial cause, which is unique if you compare with the croup. If the patient has epiglottitis.
No, ठीक. Huh? Hello?
Yes. Hello? Can you hear me, guys?
You are audible, sir.
Okay. So my question is that if you found the patient is having the bacterial infection, what would be the unique step you will take it for that? If you found the antibiotics, okay?
Yeah. Yes.
Antibiotics is very important. In epiglottitis, you have to mention this finding and then you have to stop. But in croup, you don't have to go for it, okay? And the important thing in croup is the score. It's very important because in RChem, they will ask you what is the score and your intervention according to the score, not the way you go, okay? Now let's come up, I'll show you how. Okay, so this is the score and stridor known of agitation 1, the 2, and what could be the severe, guys? What could be the score? It's quick, very unique, important point. Tell me that what leads to be the severe case.
Diagnosis.
Okay.
Score of 13, SpO2 less than 92, and conscious level low.
Focus on saturation, only 1 point, very important. If you find the saturation low, think about severe. That's it, and take intervention accordingly, okay? Rest of them mild to moderate, always consider to go with the first lines and without the nebulization with adrenaline. If you found a severe case, nebulize with adrenaline, okay? Now let's come up to, I have added the important table. You can see the group life-threatening features, cyanosis, and also the decreased conscious level. If you found this, go for 100% oxygen and nebulize with adrenaline and call the anesthetic. Very important. In semen bacterial infection, if patient is having this, you'll nebulize with adrenaline and then you will take the further intervention. Okay, so the mild and moderate, always go with the Daxer oral, okay, and 30 to 40 milligram, and or in severe cases, you will go for both and also require admission. This is for the treatment, but I just want to tell you that how you can, what step when you need to give the adrenaline. Now, how you will know the adrenaline, guys? When you will know the patient is, which step you will know the patient is in severe case? Which step of resuscitation will guide you the patient is in severe case?
A.
Yes, yes.
No. Yes. Oh, sorry.
Yes,
Someone said B. Someone said B. A can guide you. The patient has the stridor, but it cannot confirm you that the patient is severe or the mild or moderate. So where you will know it's mild or moderate, guys, in B. Okay, in B you will see that the saturation. In B you will go to check, for example, air entry. Okay, B can guide you everything, and you will know also the chest expansion. Okay. So in B, you will know about the patient is in severe or in mild or moderate. But in A, if in A, patient present to you in unconscious, then it can be also severe. But likely in A, they don't give you. They usually give, patient has a stridor, and that just, and then if you ask for the, there are a few other things. If you ask her, look for sign of airway compromise, like includes cyanosis or ceasal breathing or use of extracellular muscles. If you ask her, if you give you idea, if she gives you an answer, like they are, then you will go for example, to actually go for to nebulize, give the high flow oxygen, nebulize with the adrenaline, and also give the Daxer, 0.15 mg per kg to that patient per oral. Okay, if not, then you will go for the batonicides if patient is unconscious and vomits. Okay, so I would say in generally speaking, we can know about the patient in severe case in B, not in A. But if you ask the nurse in A, for example, patient has a stridor, and you know the patient is 2 years old, under 2 years, like 15 months, 18 months, 16 months, whatever. And then you ask the nurse, is the airway, could you please look for the sign of airway compromise and other like cyanosis or ceasal breathing? If she gives the answer, good. But if you don't ask, no problem. Then you ask the nurse, open the airway, okay, check for secretion, anything, any foreign object you have to remove if there is, but I don't think so for that. She will say no. And then you will ask the nurse, please give, the patient is unconscious, and then you will ask the nurse, please nebulize the patient with batonicides, okay? But if the patient is conscious, then you will ask the nurse, please give the patient or the administer 0.15 mg per kg Daxer. Okay, or give the orally.
Dr. B, I want to ask you one relevant question, that the life-threatening signs to differentiate between the severe, between the life-threatening and the mild to moderate are two, as you mentioned. One is the conscious level
when the other one is the
Yes.
oxygen. So at which stage we can see the conscious level? Either it is confused or that's why.
Look. If you see the upstairs here, at the top, is the patient here? The patient arrived? Is the patient alert? Here, maybe she can give you answer. Unconscious. Look, listen, feel, less. There is life.
So it means that not in the B, that from the A also we can predict that patient is in the life-threatening situation.
That's what I said. You can, but less likely to give an in that place in A. More commonly, you can find in B. Why I'm saying the B, you will know the saturation there. Okay, you will know about the chest rising there. You will check the air entry there. The actual point is B, but it can be given in A. So in A, of course, so if they say the patient has a stridor, only patient is conscious, only a stridor, then you just go for the Dexter, or if the patient is conscious, you just go for Dexter. If patient is unconscious, okay, and the patient cannot tolerate, then you maybe go for Betsonide. But here, first you will go for the how to say, the adrenally nebulization, high flow oxygen if patient is unconscious. Both can be given is this algorithm mentioned. In severe cases, and also here you can say life-threatening cyanosis or decreased level of consciousness, 100% oxygen nebulized with adrenaline. Okay, so this is very important. But if you follow the guideline, it's also said you should give the Dexter. If patient is unconscious, you also need to nebulize with the Betnoside. Okay, where is that one?
Dr. B, one thing is not clear with me. If the signs of airway compromise is there, and can we intervene in this case with the oropharyngeal airway suction or like this?
No.
Or the maneuvers?
Look, guys, the few things I want to tell you. Some treatments are according to guideline. Okay, stridor is here because of what?
Due to the laryngeal edema.
Yes. So, first of all, in epiglottis, you even cannot use a tongue depressor. Do you know that? Yeah. So, if there is secretion, then you can suction it, but you need to be very careful. In that case, you need to call only anesthetic.
Oh.
Then and to decrease this edema and this severity, you maybe go for, if patient is conscious, you need to go for oral Dexter. Okay. But if it's severe cases, in that case, you will go for example, you find that the patient is drooling and having a lot of difficulties. I said when you come in the B, you find the saturation is dropping, then you will go for the adrenaline nebulization. Okay. So this intervention, so here I can focus two things. Number one, the first one is important, is a score, how you take the score, and your intervention should be according to the score, not according the way you want. For example, if the patient is unconscious from beginning and you are finding this a severe case, and here you ask the nurse just to give the Dexter per oral, that doesn't make sense. Or nebulize with Betsonide doesn't make sense alone, right? But what you will do here, you will ask the nurse, please give the high flow oxygen, nebulize the patient with the adrenaline, okay? Then move further. Then come up to the B, then further intervention. But if it's a mild to moderate patient is conscious, just a stridor, then you will ask the nurse, please give the Dexter 0.15 milligram per kg per oral to this patient. And meanwhile, I continue my assessment. I will go for B now. But another important thing, for example, now you're not sure about it's a croup or it is the bacterial cause. So what you will do, guys, here in A, if you're confused, now you're very much confused about that, whether you need to go for the nebulizer with adrenaline or whether you have to give the Dexter or not. And now you know the age also not help you to find out. So what you will think, for sure, in the exam you will not have that much complex, but what you will think, how you will intervene. How? Then what you will do, you'll ask the nurse, do we have an X-ray? Okay, the neck lateral view X-ray could help you with the thumbprint sign. It can help you if it is epiglottitis. Okay, but it's less likely you will have that much complex. In the age, it will be very, very obvious this is going to be CRIP if less than 2. Okay, so in B, you will go for connect monitor. This will also give you an idea if you find less saturation, not air entry is not equal, then you have to think of severe, and you will ask a nurse, please, if you didn't give the high flow oxygen there in A, you will ask here in B, please give the high flow oxygen to this patient and also nebulize with the adrenaline as soon as possible. Thank you. And also, one more important, please call the anesthetic because patient may require intubation later. Then you move for the lung sounds. Now expose the chest of patient, do inspection. Inspection you do by yourself, palpation, check the trachea, the chest expansion also with your 2 hands. Percuss the chest, then oscillate the chest. After that, you have to go for the house sounds, murmur, etc. But if still you have confusion, then you may be asked the nurse to do a neck X-ray or the chest X-ray. Why do you go for chest X-ray, guys? Anyone can tell me?
Foreign body.
Foreign body, to rule out the foreign body. Okay, so you will go for the parameters, the severe life-threatening loss. Yeah, that's correct. The circulation, then you will go for fluids more likely, and this patient require the admission, and then you will hand over to relevant specialty. But as I said earlier, if it is epiglottitis, then what you have to do after E, you find the temperature is very high, and you think it goes to the epiglottitis. But how you will know? Another reason may be immigrant. They will mention the recent family moved to England and this child developed this infection. So in that case, you can suspect, and then you will start the antibiotics. But for that, as I said earlier, the age is also important, and you will order the lactose level, the blood culture, etc., and ask the blood reports in after E. If they give you anything like that, then you will suspect this bacterial infection and start the antibiotics. That's it. And after that, you reassess the patient and hand over. So what is very important in this station, guys? The score is very important. Your intervention should be according to the guideline, not according to you. It's very important. So you should be very careful when to nebulize with the adrenaline, when not, when to give the oral Dexter. Okay. Now let's come up to our next station is about, I guess, is sepsis. Yeah, sepsis we already clear about. In the last station, we are going to have the second last is the pediatric asthma. Okay, so who can tell me how to run this station, guys? What is very important? The same way, the airway, and so the important you can find the difficulty in breathing, and you have to take intervention according to it. But very important in B is what? P expired. Yeah, PEF is very important. Okay.
PK expiratory flow.
Yes. PEF is very important. Another is about the severity of the asthma. That's very also important because you should know when to nebulize the patient with the salbutamol, when to give it the PMDR. That's very important. When to give MDR, through MDR, when to go with the nebulization. That's 2 or very important. How many puff you have to give it, like Litane Okay, if not improve, then when to nebulize. That's very important. And I took out here is attach the table. According to BTS guideline, the moderate is the saturation. Okay, you need to find unique points. For example, in acute and severe, one is the saturation is low, okay? Another is heart rate depends. But in life-threatening, saturation low, but also the chest silence and the altered conscious level cyanosis. So this 2-3 points very important.
In life-threatening, carbon dioxide level is normal, but in near-fatal, carbon dioxide is high.
We are in children.
Yeah.
The adult is different.
Okay.
We are in pediatric. We are not in adults. It is a little bit different than the pediatric. Okay. So here a little bit different. Here is moderate and acute and life-threatening, but there is no I think there is one more. Okay, so here is the PACE less than 33, solid chest, and also the sinus. This is a very important point. But here is in acute severe is less than 92%. That's a very important heart rate. Put in your mind. That's it. Two important point, but there is no heart rate in life-threatening. Now, what you were talking about, that was in adult. Okay. So we are here, and the management is also according to it. So can you guys tell me, who can tell me when we need to go for nebulization, guys?
When the oxygen goes beyond below 92%.
In severe asthma.
Yeah, in severe we have to go for with the nebulizer and also life-threatening in both cases.
Yeah.
But in moderate, the first line is what we have to go for?
MDI.
Yeah, MDI, and also we have to go for the oral steroid, prednisolone. Okay, this also we have to give, and then reassess. So please check out the management plan for that, and you have to intervene accordingly. Like again, you need to focus on B. Where? B will help you to help you to categorize the asthma. Either it's severe or it's moderate or it's the life-threatening. So catch the category here and then intervention. For example, then you will ask a nurse, okay, I see the saturation is low. It's likely patient has the severe asthma. Please give the salbutamol with nebulization or with the MDI. Okay, the circulation always not really a big problem because in asthma mostly problem with the B. Okay, and then you herbalize the finding. The same if low blood pressure, you give the 10 ml, and disability, and that's reassess the patient. And then second line drugs. Okay, what is the second line for the severe, guys?
Magnesium sulfate.
Okay, before that,
IV steroid.
Look. Salbutamol,
then
steroid, ipratropine bromide. Yes, that's correct. The steroids, okay, and then the ipratropine bromide, okay, with what? Beta-2 bronchodilator, salbutamol with salbutamol, okay. And if no improvement, then you have to think about magnesium sulfate. It's about the severe, okay. Again, in life-threatening, in all cases, you have to give the oxygen in both acute, severe, and life-threatening. Again, oxygen via face mask, bronchodilator with ipratropium in life-threatening. And again, you have to repeat, and the oral prednisolone, the steroid, and then you will discuss with the ICU. This is according to BDS guideline. So remember, this is intervention, because if the first line is failed, then you will have to come up for the second line when you reassess. and you have to intervene accordingly. So most important focus would be in B all the time. Okay, I think it's very easy station if once you got it, but my focus is, again, it's guideline. You should follow the guideline. Not every station. If the patient is moderate or the acute severe asthma, the intervention you take, the life-threatening, it doesn't make sense, right? They know it's, you know how to run the station, but if you don't follow the guideline, that means you're doing a malpractice or you're going blindly. So that can reduce your score. Anyway, let's come up to the last station is hypothermia or conjoining patient. So it's also came in previously, the same like adult, but one important thing I want to make sure is also unique station. You will ask the nurse to please prepare following low-grade thermometer, warm blankets, turn on the warm air conditioner, prepare airway equipment, suction, oxygen, etc. And also following the equipment like drugs, warm IV, fully cardiac monitor, BB curve, etc. Again, here is the patient here the same way. Please check the temperature. Temperature is more important. That will guide you what intervention you are require, whether the patient need a warm blanket or not. And now you might think like, if the patient arrive, okay, is the airway patent? That's wrong. You're going wrong, because what intervention first require you have to do, you're not going to maintain the temperature. You're not going to remove the vac close. You're not going to rewarming the patient. So it doesn't make what action you're going to take totally is run the station wrong way. So remember, so you have to store the station this way. Here, patient arrive. Okay, great. Please check this temperature with the low-grade thermometer. Thank you. Remove the wet clothes and apply the warm blanket and heating packs to patient. And turn on the warm air conditioner. There is. Thank you. Okay, now you'll ask the patient alert, because in the case they will mention the patient is droning. If they mention, you have to take this step following that. Then please turn on warm air conditioner. Is the patient alert? No unconscious. Please check the sign of life, glucose and feel. No, that means the patient in cardiac arrest. Please call anesthetic ICU team. Call is CPR. But in children, you have to go for the fire rescue breath, open the airway, then fire rescue breath, and then you will go for CPR 15 to 2. Rest all things like adult. Okay, so the shock, first shock, 3 shock you will give. The rest depends on the temperature. Okay. Again, you will go for 4H and 40 is the same, because patient in cardiac arrest, just there's little modification to the resus drug and the shock, which should be given for 3 shock, but later you have to wait for the temperature, could be 30 degrees at least, and then you will go for the 4th shock and etc. Clear so far? This is the same like adult, we had to cover very well. But you need to cover here, the dose a little bit different, that's it. And the same for H and 40s here, likely cause hypothermia because temperature is below. And if the hypovolemic patient is likely, the hypovolemic patient would, the hypothermia patient are also like hypovolemic. So you also need to give the fluid if you find patient is hypovolemic, okay? All right. So once you got the upgrade score and it's around 4, so what will be your next intervention, guys? We'll bring the baby to the Resuscitaion. Yes, that's correct. Okay, then you will go for the intervention accordingly, like just open the airway. If there is any airway is not clear, then you have to suction, which is usually required, hardly ever required, but can be sometimes if there is any secretion or mechanism. So in that case, you have to suction and clear, and then you will go for the 5 the respiratory breath, inflation breath, okay? And then you will know the chest expansion or not. The inflation breath will be in the air. If you found the chest is expand, that's great. If not expands, then you will again try 2% technique, and you got it. And then you will go forward with the stethoscope, the heart rate. And if you found it's low, plus 60, then you will take intervention calling. So this is how we go for it. And I will again go forward to show you that slide. Okay. Let's come up to the next one is, for example, a child is with mother in the restaurant and eating, and suddenly he is distressed. So what could you suspect in this patient?
Anaphylaxis.
Anaphylaxis, that's correct, anaphylaxis. So see, what would be your intervention initially? Now the baby is in the ED, in resus room. You got it. And the baby is, I would say, the talking. Okay. Baby is talking. That means the airway is patent.
Yes.
Adrenaline according to.
Adrenaline. We will check the question.
No. You are not going for the adrenaline now because patient is talking. You're not sure of that right now. When you, because the rate, if it's mentioned, if I say there is the lip swelling or etc., that you will suspect that's confirmed that it's going to be anaphylaxis. But if I say the airway is patent and there is nothing, any sign I tell you, that means it's okay. And you just because of rash, you cannot make sure that it's anaphylaxis, right? Just a lone rash. So when you will come to circulation, maybe I will give you the low blood pressure. And that time you are going to first time to intervene in this patient to give the adrenaline, okay? So the airway, if patent, patient's talking, and I didn't give you any feature, then you have to go for the B, and then you come up to say, and you will find likely the anaphylaxis. Otherwise, the alone rash cannot help you. But if it's mentioned the facial swelling, that can give you an idea. If there's facial swelling, likely the airway wouldn't be patent. So this intervention, as I said before, also you will take accordingly, okay? All right, so this is about that. And now I'm going to tell you about another patient who is drowsy. And what I mean by drowsy, guys, sometimes I found some candidate get confused with the drowsy. Can anyone tell me what I mean by drowsy? Anyone can tell me about drowsy, guys?
Decrease GCS?
No, I just ask you simple meaning of drowsy.
Lethargic or sleepy.
Yeah, that means sleepy. Means very weak child. Okay, so sometimes people get confused. What mean by drowsy? What mean by that? Okay, it's nothing to do with that. So you don't have to confuse like this kind of things. Okay, and you have to if you found it's in the, if someone say to you patient is drowsy, etc., you just apply the hypoflaxin, okay, and go for the next. But you don't need to consider like it's not normal to I mean, it's that doesn't mean that the airway is not patent, okay? So you have to be very, very careful. Someone is opening the video, please. Could you please close it? Thank you. Okay. So you found it, the baby is drowsy and the parents are really worried about it, and they brought this baby in the ED. Okay. So what could you suspect in this baby? And the baby is old, around the 2 years old, I would say. What could be think? What do you will think about that baby? It's likely can be goes to the any infection series, right? And when you will go for the resuscitation, you will find out. So it's going to be likely to that. So we have also station, we will practice about it. So what is the intervention if you found the baby is drowsy and you go for the lactal level is, for example, low blood pressure and lactal level is high. So what would be your intervention? In C first C, okay, and then also in E you found the high temperature and also rash. So
meningoencephalitis. We suspect meningoencephalitis.
Okay.
meningococcus septicemia, right? Why I'm saying that in the exam they will not mention the way you are practicing. For example, when you're practicing somewhere, maybe you already know the station, but in the exam you will not know it unless you have to find it by yourself. So very carefully you have to run the station, especially if you think about sepsis. Okay, when you suspect sepsis, then you have to go very carefully in the end till the E. Okay, so this is very important, because in the E you will get many things. For example, temperature, high temperature can be, you can get it, and also the rash if the patient has it. And sepsis, meningococcal the sepsis station doesn't mean all the time goes with the meningococcal septicemia. It can be go with the acute gastroenteritis, can be bacterial. Okay, so there are several things which can be not a single. It can be also go with the pneumonia. So you have to be ready for all kind of things. And sepsis, the intervention will be relevant to the area where you're, for example, if you're in breathing, so you have to take the intervention there. All right, so we have more things to come up, and also we have neonatal ductal the defects. So last time someone asked me about the oxygenation. Yes, we have to give the oxygen. Okay, in any case, if the patient is in shock, we have to go for the oxygen, and we have to keep the oxygenation to maximum 85. It can be stored from between 75 to 85% saturation. So this you have to verbalize if you are going to have the cessation. Okay, let's take a quick look about the I would say previous slides. I mean, which we already covered, and then we will go for the today's role play, because I want you should do very well in the role play as much as you can. Okay. In another station, we are going to have the hypothermia. It wouldn't be like the patient is hypothermic, but they can give you a station like patient is drowning, has been drawn in a canal, or it can be in a river, etc., or in the mountain camping, but it's a child, so it's less likely relevant to that cold. But if an adult, it can be the camping or homeless can be considered as hypothermic station. All right, so another is about the asthma. It's very important station, can be you have in the exam. So look at the finding. This is very important to write down or take the photo that if you're going to have this station, so you can pick up from here. Anyway, the next is about the station. We are going to, CRIP, as I said about the score is very important. So according to scores, you will take the intervention, but the fact I want to tell you, the saturation, you should be a lot focused on the saturation. If it's less than 92, it can be considered severe, and you will ask the nurse to start the adrenal nebulizer for this patient. All right, so, and status epilepticus, we already gone in the first 5 minutes, the first dose, and 10 to 15, the second dose you have to give. And you will ask the nurse to remind you after 5 minutes. This is very important. The Apgar score is here. So when you're going to assess the Apgar score, so okay, you can verbalize, okay, if I'm going for the outgoing score now, or I see the baby's pink. But when you say the baby's pink or something like that, the nurse will say, no, baby is pink at the center, but extreme is all blue. So that consider 1. When you use the stethoscope to go for the outgoing score to check the heart rate, if not connect with the monitor, in that case, she will say, okay, it's less than 100. But if you check on the monitor, it would be less than 100. That means it's again 1 score. Okay. And then you will go for the baby's crying almost, the pull aways, and that's the response to stimulation when you're going to do. If you found that if she said weak cry, so that consider again 1. And activities, you will go for it. The check for, I'm now going for tone and color, which I already mentioned in the slide that will help you. So through this way, you can go for the what could be the outgoing score for a child. And nurse will obviously able to help you with that. Okay. The next is about the anaphylaxis, which is not very difficult, and also the cardiac arrest. So the arrhythmia also we have 1 station we were going on to practice. Okay, let's come up to the overall play, and I already take a quick revision with you guys. So well, I'm going to show you the station first, and I want to see what you suspect and how this station can be goes. Okay, just want to see your idea. So you can see this case. So how do you think this station goes to where?
Anaphylaxis.
Anaphylaxis, that's great. Let's come up to this one, and you will find the sinus tachy. When you ask about heart rate and the timer will go on, you will have around 7 minutes. Okay, I will give you 7 minutes to practice inside in the station. 1 minute, you will read the case. Okay, this one, guys, what do you think? What do you think this station goes to?
Maybe asthma.
Asthma.
Bronchial asthma.
Yeah, that's correct. It will goes to bronchial asthma. The next station we are going to have is, and what do you think?
Febrile seizures.
Epilepsy.
Status epilepticus.
Yeah, it will go to the epilepticus, and likely can be febrile. Okay. Yeah. Can be febrile, but can be complex and can be simple seizure. So what about the complex seizure? When to consider is complex, guys?
More than 15 minutes.
More than 15 minutes.
That's
Within
correct.
24 hours.
If less than 15 minutes, in 5 minutes, what would be considered simple febrile seizure? And when the child need admission, guys?
When there is complex seizure and seizure repeated within 24 hours.
All right. Okay, that's correct. So this can go with anyway. Okay, it's up to me how I'm going to make it. Okay, and now this station goes to where, guys?
This is sepsis.
Meningococemia, gastroenteritis, can go everywhere.
Can go to anywhere. Can go to pneumonia. Can go to the meningococcus septicemia. And it's up to me that how to make this station for you. So it's likely goes to the sepsis. Okay. Next station we are going to have is, and how about this one? Just put your idea. It's 1 year old, okay, and it can be drowsy, pale, clammy. So I didn't give. It can goes many. I mean, not only specific to one, but you will know it's when you will run this station. It will be very easy to pick up.
Toxicology, maybe.
Can go anywhere. I will let you know when you'll practice. It's okay. It's complex. You cannot get it. Okay, how about this one?
Congenital anomaly.
Congenital. One first is like is 4-day-old, right? And is unwell, so it goes to congenital, likely congenital anomaly. But another thing, if the age a little bit like so neonatal, like I would say 25 days, 28 days, okay, less than a month, if I would mention, and a vomiting, or even don't mention the vomiting. But what could you suspect?
Maybe
It can be
neonatal
sepsis.
Cardiopathy.
Yeah.
Maybe
Can to
cardiac, maybe lung hypoplasia, maybe diaphragmatic hernia.
Yeah, can be hypertrophic pyloric stenosis. Okay, so it depends. Another way you're going to have it, this one. What could be?
This is newborn life resuscitation.
Yes, this would be the newborn resuscitation. How about this one?
This is croup.
Maybe croup.
Or yes, more likely to be croup, because it's under 2. But if the age is greater than 2, you can put both. Yeah, you can put both, unless you when you run the station, you will know more about it. So if it is more than 2 years, then you have to put both on in the epiglottis in differential, or you can suspect that one and put croup in differential. All right. Okay, so next we are going to have this one.
Drowning.
Drowning, and is going to there. Hypothermia. Yeah, it's going to that. And please, you have to check the rhythm. This is a fibrillator monitor, and it's showing like that. What do you think about that? Yeah, that's correct. So it shows you that one, and that's correct. Okay, so something you can get on when you're doing the practice. You have to focus on the monitor. So this will also help you, and you don't have to ask each and everything from the nurse. For example, what is the heart rate? Even the monitor is in front of you. Of course, she will say, please look at that. Okay, so if the monitor is attached, either defibrillator or another monitor cardiac, so you have to look at that carefully. Because some intervention you have to take through that way. For example, you see the saturation, you don't need to ask her in a B, what's the saturation? Okay, as I see on the monitor, the saturation is 92%. That's okay. Or you can say, I see the saturation is less than 92%, please, and also other finding, and then you ask the nurse, please store the adrenaline nebulizer for this patient. Patient is having severe croup. I'm talking about a croup station. So you can pick up the finding from the monitor, and then you have to verbalize that and ask the nurse for the intervention. So this way you can go, okay, not everything all the time to ask a nurse would it make sense. That means you're unprofessional. The professional means the things are available to you and you have to take the advantage of it. For example, the monitor is attached and you're still asking the nurse, that doesn't make sense, okay? Because monitor is showing, when you verbalize what you see on the monitor, if that is correct, the nurse will correct you. That means you don't need to focus. But if you focus on monitor and you verbalize and take the intervention, nurse doesn't stop you, that means that monitor is important and you have to focus on it, okay? So this is very important things you don't have to forget. Every station when you get in, especially in resuscitation, You focus on the equipment which are available there. You don't need to ignore them, okay? This is very important. All right, so we are going to practice, and you already know the station. I want to tell you one thing, that I am not a good the actor, okay? I'm not a good actor, but I want you should do everything perfectly. You should follow the approach. You should follow the, make sure what intervention you are going to take it. It should be according to guideline first. Where you record the score, you have to take the score, all right? And I will see, I will pick up the important points if I found you or missing. So, and everyone should listen to each other, okay? I mean, if, for example, if someone is performing the role play, others should also listen to him or her carefully and note the points and help me to correct him, okay, together. First, I will put my idea, and if someone want to add some points, that's welcome too. All right, so who wants to do the first station, guys?
Me, Dr. B. Dr. Tasneem.
All right. Okay, let's make it better now. One second. Okay, you have 1 minute start now.
Okay, ready? They didn't tell me how many nurses I have.
No, you don't have to follow how many nurses you are. You are going to have more. It's just the case, okay? If it's mentioned one, you don't have to. You will have more than one, okay? It's not necessary you will have only one, okay? But if you found two, you have to work with it.
Okay. Hello, I'm Dr. Tasneem, ED registrar. May I confirm your name and grade, please?
I'm Katie. I'm the nurse.
Nice to meet you, Katie. We have a pre-alert 5 years old boy. He have a shortness of breath and distress after eating in the restaurant. Are you comfortable to deal with airway and prepare airway trolley and oxygen mask and suction?
Yeah, sure. Thank you.
Okay, and also I need you to dealing also with circulation and prepare cardiac monitor and IV access and blood pressure and also defibrillator, and also I need resuscitation drug. Okay.
All right.
Okay, let us clean our hands, wash our hands, and wear our PPE. Did the patient arrive?
Your patient is here, doctor, or he has all around the rash all over the body. Please help this patient.
Okay, is the patient alert?
Yeah, the patient is talking.
Yes, the patient is talking, airway is patent. Can you open your mouth?
Yeah.
I need to see if they be swelling or tongue is swelling.
Yeah, there is no tongue and lip swelling.
Okay, I'm happy with airway. Airway is patent. I need to assess. I'm going to assess now the breathing. Okay, please, sister, can you attach a cardiac monitor and pulse oximetry? I need to know our respiratory rate and oxygen saturation for this patient. While I will export the chest and check by inspection. There is any abnormality in the chest? Any rash?
Yeah, rash all over the body, doctor.
Okay. By palpation, trachea is central, chest expansion. Is the trachea central?
Central.
Chest expansion is equal?
Equal. Normal.
Percussion, 6 side, 6 area.
Normal.
Auscultation, 6 area
Wheezing.
also.
Wheezing on both sides.
Okay, what is the SpO2 and respiratory rate for this patient?
Saturation is 93%.
Respiratory rate?
Respiratory rate is 20.
Okay, please sister, attach this patient to high flow oxygen by a non-rebreather mask. Okay, and let us continue our assessment. We will start with, we will continue to see circulation. Okay, please attach all the monitor, and I need to know blood pressure and pulse rate for this patient.
The blood pressure is on the monitor. Doctor is 80 by 55.
Okay, pulse rate.
Pulse rate is 120.
Okay, CRT 1, 2, 3 in the sternum.
CRT is greater than 2.
Okay, this patient in shock, and this all sign of anaphylaxis. Please, sister, give patient one shot of adrenaline. I am in the anterior lateral middle thigh. Okay, that.
Okay, to given. Yeah.
Hello?
Yes, no, adrenaline given.
Okay, let's continue and give him also 10 ml per kg normal saline bolus. Okay, let's continue our just please notify me after 5 minutes. Okay, let's continue our assessment. What about the disability? Please, sister, can you take random blood sugar for this patient while I'm assessing the GCS for the patient? And what about the GCS for the patient? AVPU, is the patient alert?
Patient is unconscious now. Before was talking.
Patient unconscious. Any sign of life? Look, listen, and feel.
Yes, there is. There is sign of life.
There is sign of life. Okay. What about what is about airway? Airway is patent.
The blood sugar level is 5 millimole.
Okay, blood sugar level is normal. I need to reassess the patient. Patient unconscious now, you told me.
Yes, patient is unconscious, but there is sign of life.
Patient unconscious, please, sister, call anesthesia. This patient needs intubation. Okay, and start the back valve mask. Okay.
Okay.
What about the SpO2 for this patient? Respiratory rate?
Doctor, go for E and then reassess.
Okay, I'm going to continue for disability.
What is the temperature?
What's the temperature of this patient?
Yeah, 36.8.
Okay, there's a rash all over the body, you told me. Okay, please, we need to reassess this patient. Give him the second dose of adrenaline. 5 minutes past, please.
Yes, 5 minutes passed.
Give him the second dose of adrenaline. Okay, 0.3 milligram. 1 in 1,000. Okay, anterolateral also. And let us reassess the patient. Okay, what about airway?
Airway is now patient has the tongue lip swollen.
Tongue lip is swollen. Airway patent or not patent?
Not patent.
Okay, head tilt chin lift, airway patent now?
Not patent. Patient has tongue swelling and lip swelling.
Okay, continue give him adrenaline. There is OBA or MBA.
Yes, we have. Nasopharyngeal airway.
Yes, patient tolerated for MBA. Okay, please touch connect MBA, insert MBA, and high flow oxygen via breather mask. Okay.
Okay.
Airway is patent now.
Airway is patent now after in the NPJ.
Okay. Now we'll assess breathing. What's the respiratory rate and SpO2 for this patient?
It's 94% now. Respiratory rate is 20.
Okay. What about blood pressure and pulse rate?
Still low. Pulse is tachy.
Okay, this patient entered in refractory anaphylaxis. Please call ICU team, and we will continue adrenaline IM every 5 minutes till preparing adrenaline infusion. Okay, please prepare adrenaline infusion 0.1 ml. From 1 to 1000, we will give him 0.5 milligram per kg, 0.5 milligram per hour infusion. It will be put it in 100 ml saline. Okay.
Okay.
Okay. Continue to assess the patient.
Mm-hmm.
What about airways patent?
Yeah, airway is patent now.
Breathing, SpO2 respiratory rate.
94%.
Respiratory rate normal.
Normal.
What is the respiratory rate? Okay. Blood pressure.
Blood pressure is better now. Normal. Improved.
Okay. Pulse rate is normal.
Normal.
Okay. What about GCS of the patient?
GC alert.
Alert. Okay. What about temperature is also normal?
Normal.
Okay. Any team to endorse?
Yes, there is ICU team.
Okay. Hello, I'm Dr. Tasneem. We received 5-year-old boy. Background. He had a background of shortness of breath and wheezing after eating in restaurant. After assessment, after assessment and examination, I found there is wheezy chest and low blood pressure. We give patient adrenaline, 2 doses IM, and we start infusion. Patient now all the parameter is normal for your kind care.
Okay, thank you.
Thank you.
Actually, this station could be run very simple, but I made it complex because you missed many points. For example, in C, you missed the points. You haven't taken the blood. You haven't taken the investigation. You forget the trip test level. I supposed to go with this station in categories later on, but I want to check you what intervention you can take it. For example, if I said the patient was talking in reassessment, I said patient has lip and tongue swelling, and that means you have to go for NPA, nasopharyngeal airway. So, but it's okay. You overall did well, but you are making some, I said, very big mistakes which you're doing. You're forgetting the investigation, your intervention especially. Okay, adrenaline, you did very well in C. And then the adrenaline, which you went after E, which is not correct, okay? Unconscious, but patient has sign of life, you just have to move on, okay? It doesn't require, because in that time you may need to ask about his 5 minutes past. That makes sense, but then you have to just move on. You don't have to come back to that place again. And when you come up to the reassess, and I said the lip tongue swelling, then you have to go for second dose. All right, because patient is worsening, not improving, but is getting worse. So that means you should go for second dose there. And while going for second dose, you have to ask me to prepare for the infusion, okay? Because patient require infusion later on, okay? So, and also call the anesthetic. So it doesn't mean that you should wait for C or another place. So you can take if anaphylaxis airway compromise, you have to go for adrenaline. If airway is not compromised, that means if it's anaphylaxis, the circulation can be compromised. So it depends. Sometimes you can have to manage at the place of A. Sometimes maybe they give you extraction maybe a little more complex in C, and then in reassessment again to take you in A. So this is very important. You have to take the steps accordingly. It doesn't mean that you should skip that. And for example, your second dose skip in again when the patient has been deteriorated, and you have to verbalize also after second dose this patient is in an anaphylaxis, refractory anaphylaxis reaction. Please start the infusion. Okay. If you forget to verbalize the infusion rate, it doesn't matter. Okay. If you will have time, the nurse will ask you a question in the end how you start the infusion, or at the same place, the nurse may ask you, could you please help me? I don't know how to make the infusion. Then you have to verbalize. Otherwise, you just mention start the infusion. That's okay. All right. So you should be, I give you more time because it's your first time to practice in the first station. So it's normal. But when you practice again and again, you will be better. So any other candidate who wants to do the same station?
Yes, okay.
Yes.
Okay, let's start the same station again. I give you a few seconds to read the case again. And then we start again. Start now.
Hello, I am Dr. Mustafa, Emergency Registrar. May I know your name and level, please?
Just on KT, I manage the airways. Yeah.
Okay. Okay, sister, please prepare difficult airway for difficult airway trolley. And another sister, you need to prepare the circulation with suspected patient came by ambulance with the restaurant with shortness of breathing. Okay, and call the pediatric resuscitation team and ICU alert for this. I wash my PPE. Any endorse from the ambulance?
Yeah, patient is here. Patient is
What
over
about
in the body, is rashes over in the body. Doctor, please.
Patient is conscious. What about the abuse score?
Yeah,
what about
patient is, yes, patient is unconscious.
Patient unconscious, look, listen, and feel. Any pulse?
Yes, there is pulse. There's sign of life.
What about airway?
Doctor, the child is having a tongue swelling or lip swelling, and it's very difficult to know.
Okay, please, I put nasopharyngeal airway.
Doctor, how to insert the nasal NPA?
There is MBA or MBA. There is MBA fits for MBA.
Yes, how to insert, doctor? Can you please do it?
Okay, this lubricate and insert perpendicular.
Okay.
At the angle sizing between the angle of the nostril of the mouth of the
Okay,
nose.
doctor. NPA insertate.
Okay, okay, please, and give high flow oxygen 15 liter. I will go to the breathing.
Okay.
What
Okay,
about
mask is attached.
What about the SpO2?
94% on oxygen.
What about the respiratory rate?
Respiratory rate is 20.
By inspection of the chest, any abnormalities?
The trachea is central. The inspection or in the rash or in the chest.
Okay, by palpation.
Yeah, trachea is central. Chest expansion normal.
Okay, what about the percussion? Auscultation.
Auscultation is wheezing bilaterally.
Okay. I am going to see what about the blood pressure.
Blood pressure is here is 120 by the 60.
120 over 60. Okay. What about the CRT?
CRT is less than 2.
2. What about the pulse?
Pulse is slightly tachy.
What about the rhythm?
You have a sinus tachy.
Okay. Please call to the sister. Please call to the. I want to call to the ICU and start adrenaline. 150 at anterolateral thigh, and take investigation, CBC, biochemistry, and tryptase, and VBG.
Okay.
Meanwhile, go to the disability. What about the score? Glaucoma scale.
Patient is unconscious.
Patient unconscious.
Response, yeah.
Okay. Look, listen, and feel. In sign of life.
No sign of life now.
5, give 5 rescue breathing. In sign of life.
No sign of life.
Okay.
Sign of fire rescue breathing.
Call the resuscitation team and pediatric team and start CPR conversion 50-2 and take care for ambubac and stop and switch and analyze the rhythm. What about the rhythm?
It's here on the monitor. Non-shockable.
Okay, so this start. Please continue CPR and give adrenaline 0.1 milligram per kilogram according to weight flag, and list to revise 4H and 4Ts for H for hypothermia and hypothermia for hypo or hyperkalemia, hypo or hypervolemia, and T for tension pneumothorax, thrombosis, and T for toxicology also. Stop. 2 minutes pass.
Yes, 2 minutes passed.
What still there is? Continue CPR.
Still the same. Still same.
Continue CPR.
Okay.
For most likely this patient with anaphylactic shock.
Okay. Okay. Hypoxia.
And for
which is managed by the oxygenation.
Patient gone with oxygenation.
Okay.
And, no history of trauma for tension pneumothorax. No history of
2 minutes passed.
Okay, what
2
about
minutes
the risk?
passed.
What
Is
about
sinus
the risk?
taky now? Sinus.
Okay, thank you guys, for this job. I have a patient with anaphylactic shock. ICU, it is came.
Is here, yeah.
Okay, I have one patient came with ambulance with restaurant with anaphylactic shock. I give adrenaline. Then after that, patient arrested. Then this patient for kind care, patient in the cardiac arrest for BIA, I given adrenaline. Then sign came back. This kind for care for you.
Okay. Thank you. All right. Why did you forget to give adrenaline? Hey.
Both of the candidates mistake in giving the adrenaline in the in the earlier scenario and this scenario. And the scenario is mentioned that there is a while eating in the restaurant, the baby got the rash and the difficulty in breathing. So this is very much evident in the scenario that the patient has anaphylaxis, become distressed while eating. So and there is a rash. So this is a clear idea that what is going wrong with the baby, and the baby is going to have an anaphylaxis. So first of all, when we go for the airway, is the airway patent? Is there any lip swelling? Is there any tongue swelling? If there is any lip and tongue swelling, then go for the pass the NPA, nasopharyngeal airway. Now, please nurse, give me the NPA, and I will measure the size from the nostrils up to the tragus, and I will insert the tragus and will attach the high flow oxygen with non-rebreather mask at 15 liter per minute. And as well as, because I am suspecting that the baby is having the anaphylaxis, please give 150 microgram of adrenaline in 1 into 10,000 into the 1 into 1,000 into the anterolateral mid thigh, right thigh. So I am happy with the airway. Now I am going towards the B part, and the B part, how is the trachea center? Is the neck bone distended? No. So please nurse, attach the pulse oximeter and the NIBP and the vital monitor. I am going to expose the chest of the patient. Is there any abnormality finding in the inspection? Is there an abnormal on the palpation, expansion, and the 6-point percussion and 6-point auscultation? You told that there is a wheezing in the bilaterally chest. So the patient is having a anaphylaxis. Has the 2 minutes passed? Okay, yes. So I give the second dose of the adrenaline, 150 microgram, 1 into 1,000 into contralateral and to lateral part of the mid thigh. And now I am going, please nurse B, attach the get IV access and get the blood for full blood count, VBGs, U and E, serum tryptase level, and the toxicology screen, and as well as please give the IV bolus of 10 ml according to the wet flag, the fluid bolus. So at the same time, is how is the BP? How is the now I am looking at the monitor. The BP is according to the age. If it is about 70 or 75, it means this is a patient is in a shock, and the heart rate is 120 and 140. So it means also shock. CRT more than 2, it is also shock. So I am suspecting that this baby is in anaphylactic shock. So I am so please nurse be prepared for this has the refractory anaphylaxis. So please call the anesthesia and give the be prepared for the endotracheal intubation, as well as prepare this adrenaline infusion. Or by the time the adrenaline infusion is not prepared, we continue with the adrenaline, giving the 150 microgram into the thigh until these IV access or the infusion is not prepared yet. So has a 5 minutes passed? No, please attach this infusion of the adrenaline 0.1 to 0.5 microgram per kg body weight per hour. And has the team arrived? How is the response? Now I am going towards the D part. How is the people? How is the ABPU score? How is the blood glucose level? And if the blood glucose level is less than 1.5, then give glucose according to the wet flag. And is there any lateralizing sign? No sign. No, I am going to expose the all the from the head to toe. Is there any rash? Yes, there is a rash. So it means how is the temperature? If the temperature is 32 to 36, is okay. Now how is the team? Has the team arrived? No. So I will continue with the management, and this scenario will go like this.
As doctor, this adrenaline after the primary assessment and should give after second primary assessment and secondary
It's
assessment.
okay. Let's come up to, so how many of you guys have watched the adult resuscitation? The problem is like the adult resuscitation I already posted, so I said before to watch it out. The difference would be only in the doses, okay, not really a big difference in some stations, especially in anaphylaxis. So this guy said right the same exactly. The problem is that the scenario is like that, but sometimes when you come up inside in the station, maybe the station will be not run the way you were thinking to. This can give you an idea the case this is going to be anaphylaxis, but you will never know about the intervention, whether you needed to take in A or you need to take in C, whether you need to take the intervention in the reassessment. So you will never know about it. So that's why I made the station, the first station, I took it in account about the circulation. So I give the low blood pressure, but the airway was okay, and the breathing was went very well. So the anaphylaxis systemic compromise. So systemic either is a cardiovascular or the respiratory. It doesn't matter. Any one of them will be compromised. It's called, that means the patient has the anaphylaxis reaction. That's why when you come up inside in the station, maybe you can confuse that, well, the airway is okay, but the patient blood pressure is low. So it depends. It doesn't mean that both can be compromised at the time, but it can be compromised single system. So any of that rash with any systemic compromise, you have to think of anaphylaxis. So that's why I made in different stages for that. For this candidate, I compromise the airway, so he has to go for the NPA, and then he have to go for the set times, have to go for the adrenaline, the first dose, but you have to mention which area, which side, which limb. So this is very important. And then he come up to circulation, which I make it normal. Then eventually I make the patient in cardiac arrest, and I want to test him how his intervention would be here. Okay, so he has to follow the APLS protocol when the patient goes to a cardiac arrest. And when he goes to 4H-fortes, there is airway compromise. That means hypoxia, 4H-fortes, hypoxia, hypovolemia, hypokalemia, okay, hypothermia. These are 4H. Fortes, toxin, tension pneumothorax, thrombosis, etc. So these are very important. So in this case, he's supposed to say hypoxia, but however, hypoxia is managed here. Patient goes likely in cardiac arrest, can be the airway is compromised due to hypoxia. However, hypoxia is managed with the high flow oxygen. So this he has to mention. And he also need to mention in hypovolemia can be likely in this case is the patient went in shock, as can be. So you have to take the intervention to have to mention the 4H-forte toxin less likely in this case. Tension pneumothorax is less likely in this case. Just to quick rule out. After finish 4H-fortes, he has to go for, to say like, has 2 minutes passed? Okay, passed. What about the assess? I made the complex because he didn't go very well with the 4H-fortes. So I am like examiner. I want to see him he should go with the 4H-fortes. He should find the cause. What could be the reversible cause for this patient? And it was hypoxia and also the hypovolemia. So he has to go with that. And that was the important things that I want to stress out. And he didn't go with that. And that's why I let him give it another chance. The patient is still in the same problem in cardiac arrest. For example, if he goes very well with 4H-fortes, I can stabilize this patient for him. When he asks, has 2 minutes passed? He goes for assess the rhythm. What is the rhythm right now? I would say is sinus. And then he has to go for check the pulse. Is there sign of life? Yeah. Patient got risk. I can support him, and then he can finish the station. So overall, the conclusion about the anaphylaxis, I give the different places to make the compromise the patient that you have to take the different intervention. When you go for the 2 doses, then you have to say, verbalize that, please start preparation for the adrenal infusion, as patient may go to refractory anaphylaxis. So this is very important things which you have to. Anyway, you all have done very well. It's not a big deal. And as I said, I am not a good actor. Maybe you will have the better professional, which will be very clear for you in the exam. But you should be confused, and you should think how to get out of the confusion, because you never know in anaphylaxis what could be compromised for you. So I give you to practice in both cases. The case is the same, but inside in the station, your intervention should be according to the station, not about the case the same. The case can come up in different way, not the same way as I written here. But they will mention give you clue it's going to be anaphylaxis, but it will not give you clue the patient will be compromised in C or in A. That's why I make the station for you like that. Anyway, you all are doing very well, and I think you will improve by time as you practice more. Just don't skip the important things. Last time I written very well in the adult resuscitation what I mean by 4H and 4Ts, each and everything very well. You should follow it. That's it. Okay. Let's come up to the next station. Who want to practice?
Okay, thank you.
All right. So who want to practice? There is any other than the test name? Know any other candidate apart from her? Try. There is no any issue if you try. Okay, let's go with the same candidate. I think Dr. Tasnim, right? Okay. Okay. I'll read the scenario. I give you prepare for 30 seconds.
Hello, I'm Dr. Tasneem, ED registrar. May I confirm your name and grade, please?
Yes, I'm Katie. I manage the airway.
Okay, and nice to meet you, Katie. We have a pre-alert by patient 6 years old, complaining of shortness of breath. Okay, you will prepare airway trolley, and also you will manage in circulation also, and please pre-alert for pediatricians. Okay, is the patient here?
Yeah, patient is here.
Okay, is the patient alert?
Yeah, patient is say just single word in difficult in talking. Yeah.
Okay, is the airway patent?
The airway is patent.
Yes, please attach this patient for high flow oxygen by an breather mask. Okay, and I will go to assess the breathing. Please, sister, can you connect the cardiac monitor and oxygen probe? Okay, and I need to inspect the chest. By inspection chest, any abnormality in the chest?
Yep, chest is okay, normal.
By palpation, chest expansion.
Chest expansion equal, and also
Okay.
the trachea central.
Okay, auscultation.
Auscultation is wheezing on the left side.
Okay, this patient have a wheezing in the chest, and he cannot fully continue one sentence. Okay, maybe this will be acute attack of asthma, severe asthma. Okay.
What is oxygen saturation?
What is the oxygen saturation and respiratory for the patient?
Is 91%. The respiratory rate is the 45.
Yes, this patient acute severe asthma. Please attach this patient to a nebulizer salbutamol. Okay, and I will continue and put him in high flow oxygen. You already put him. I will continue my assessment, and I will see.
Doctor, how much dose of the nebulize with the salbutamol?
Salbutamol, it will be 2.5 milligram for children. Okay.
Okay.
And I will reassess the patient after salbutamol if the patient respiratory rate is okay and SpO2.
Yeah, SpO2 is still same.
Okay, and respiratory is still high. Please add to nebulization after
respiratory rate. I told you is 40.
Yes.
Saturation is still less than 9.
Okay, please add to nebulization salbutamol, add ipratropium for this patient, 250 microgram. Okay.
Okay.
And give patient also hydrocortisone. Okay. IV. If there is no IV access, please give him a prednisolone tablet. Okay. 30 milligram.
Okay. Given.
Okay. Okay. I reassess the patient. If the respiratory rate and SpO2 is still low.
Go for C.
Okay. Now I will assess circulation. Please, sister, attach all the monitor. I need to know what is the blood pressure and pulse rate of this patient.
Yeah, blood pressure 110/60. Pulse rate is 120.
120. CRT.
CRT is 2. Less than 2 seconds.
Okay. Please, sister, attach 2 more cannulae and take blood for ABG, full blood count, U1Es, and okay, and toxicology also.
Okay.
Okay. After that, we will. Can you show me the monitor? If
Monitor.
Yeah. Take ECG for the patient and just show me the rhythm also.
Sinus tachycardia.
Okay. What I'm happy with circulation. I'm going to disability. What about please, sister, can you take sugar, blood sugar for this patient? Meanwhile, I will check GCS for the patient. APPU, is the patient alert?
It's alert.
Yes. What about pupil?
Echoreactive.
Okay.
Doctor, sugar level is 5 millimole.
Okay. Well, I'm going to assess exposure now. Please expose the patient. I will cover later. Any rash or swelling in the body? What about temperature?
Normal.
Normal. Okay. I will reassess the patient again. What about the airway?
Airway is patent. Patient is better improved.
Okay. What about breathing? SpO2 and respiratory rate?
94%. Respiratory rate is 25 now.
Okay, good. What about the chest? There's any wheeze?
It's still wheezing, but it's improved.
Okay, please, can you call pediatric ICU? I will enter this patient, and please, can you order chest X-ray for this patient also?
Okay.
Okay, let us continue in our assessment. What about blood pressure for the patient now?
Normal.
Pulse rate and CRT?
Normal.
Okay.
Hand
Okay,
over to the
the
patient.
patient. Okay. Hello, I'm Dr. Tasneem. I received this patient, 6 years old, have shortness of breath, and on examination, there is SpO2 was low, and patient he cannot fully complete one sentence, and patient on severe asthma attack, and I gave him one dose of nebulization adrenaline and ipratropium, and dose of hydrocortisone also, and patient now improving, and for your kind care. Okay.
All right. Thank you.
Thank you.
Okay, so the first of all is very important that you. Okay, so it's the case of the asthma, right? And when you ask about the airway, I told the patient cannot complete, and then you come on a breathing and you find the saturation is low. I give you an idea about the respiratory rate 40, and which is for this age is very high. It should be under 30, but it's over than that. So it's also an idea in the heart rate. Okay, probably 120 I said to you. So that indicates the severe asthma, right?
Yeah,
Is it
acute
or
severe
not?
asthma. Yes.
Okay, acute severe asthma. So the intervention would be your here is the salbutamol, but the dose you were told me it's wrong. Okay, what is the age of this child?
6 years.
6 years. So greater than 5 would be 5 mg, and less than 5 would be 2.5. The the prednisol in here you should give is 1 mg per kg, but 30 is also okay. So this is very important. You have to say, and then you can also ask about here is about PEF. PEF4 is very important, peak expiratory flow rate. Okay, which it depends. If it's going for acute severe, then you can ask nurse to measure it. But if you got it, it's very good. And after that, your intervention shouldn't be staying here. You say start nebulize with salbutamol, and while going for it, you have to move forward. Okay, in C. All right. Then you go for C, and then you will go for the D and E. When you reassess, if you still found the patient is having this problem, then you go for second line treatment. Okay. Then you go for third line, the magnesium sulfate. Okay. That place, when you reassess, you have to stay there and be until the patient stabilized. But you, in a primary assessment, you stuck there and you go for the second line there, you're going for third line there, which is absolutely wrong. Okay. So you have to be very careful about this station in this regard. So let's the first important point I want to focus the dose, which you said wrong. Okay. And you didn't mention is the category of the asthma. You should mention is acute or the life-threatening. So you have to verbalize that, and then you take the intervention accordingly. Okay. So overall, you did very well, but you have
Dr.
to be.
I have one question. The patient is acute severe asthma. He can do big expiratory flow rate.
You have to verbalize to get the P4 as soon as possible. But for the P4, the patient need to be sitting upright and nicely, and then have to do. You just need to verbalize. That's okay. You don't have to going for it to do that. Then nurse will be verbalized to you the P4 flow rate, or we can say the peak expiry flow rate is blah blah less than 33%. Maybe she can verbalize to you. And that also can give you idea that it goes to which category, in moderate or acute severe or going to be life-threatening. So that's important. It's all need to go and be. So tell me another important thing. When do you need to go for chest x-ray? Anyone can tell me.
If it is not improving, then we go for the chest x-ray, or if there is a sign of life-threatening features.
Chest x-ray should be goes in the situation when your treatment is failing. You went for first line, you went for second line, and you went for third line, but there is no improvement. Then you have to order chest x-ray. Okay? Otherwise, you don't have to go for chest x-ray. So these all things you needed to stay in B when you're going for reassessment, but you will not do in a primary assessment. Okay?
Okay. Dr. B, the dose.
The dose is
for salbutamol
please
is
repeat
the
again.
patient.
Yeah, less than 5 years old, 2.5 mg. Okay, if it is greater than 5, then you have to go for 5 mg. Okay, in the prednisone 1 mg per kg. If IV,
Sir,
if
when
there
we have
is
to perform exactly.
1 second, please. When you go for the IV hydrocortisone, you have to go for 4 mg per kg. Okay. I'm talking about in pediatric. And some candidates or call the pediatric APLS team, or sometimes people say advanced pediatric the life support team. You are doing life support here, resuscitation. You don't have to call, but you can call the pediatrician, or you have to call the ICU team. Another thing, or sometimes we use code bully, but it's not relevant here. Okay, someone asked me a question, please.
Dr. B,
Sir, when
we have to measure the P4 in the B part. When we ask about what is the pulse oximeter, what is the oxygen saturation? If the oxygen saturation is low, then on the auscultation of the chest there is a wheeze, bilateral wheeze, or the one-sided wheeze. Then we come to know that diagnosis at this point that the patient is having asthma, and we have to categorize either it is a moderate or severe asthma or life-threatening. Then we have to go for the P4 at this time.
You can go pay for in a B. You have to go if you're finding the saturation and you're suspecting, then you have to verbalize. Can we have the P4 now? Because some finding you already got it in B. For example, you have got the respiratory rate here. You have got the saturation there. Okay, but if you are not gonna get it and you're still in confusion, then you can go for and say the overall peak expiratory rate should be going in B, which is relevant to it. Okay, someone asked me a question.
Yeah, my question was same. When we have to perform the peak expiratory flow rate.
Actually, when is a life-threatening condition, life-threatening asthma, you don't have. There is some specific criteria for P4. Is that patient can sitting upright or standing? Okay, but in resus patient cannot do that, all of them. But what I want to say, to categorize, you just need to verbalize, and nurse will tell you that what is the P4 for this patient. Okay.
So, Dr. B, if the patient is not responding to the first line drugs and we are stuck with the B part and B part is not stabilized, we go for the second line. At the second line, if not treated, so we remain in the B part as well as the patient is not stabilized, we will not move to the C or D.
You will not move get away from the B until patient is not stabilized in reassessment. Did you get my points? In primary assessment, you have to go for first line. That's it.
Okay.
When you will come up to the second line, and nurse will tell you, and you are finding in when you go for B and you're still finding there is not improvement, then you will go for second line. If it's still not improvement, then you will go for third line. Okay, but in reassessment, not in a primary surgery. Got it?
Thank you very much.
Okay, so
Doctor,
it's not a very complex station. It's very straightforward, but it can be complex when you run the straight and wrong way. So what I want to say this is how you got the finding, you need to go for intervention. You get the intervention first line, then you have to move to the next. Means C, then go D, then E, then you go for reassessment. That's what I say to you. You don't have to even verbalize when you finish A sometimes. If you think you're running fast or you still have time, don't need to ask about the handover. You should go for let's reassess the patient. Or also you can give a short breathing. Either you give in a B or you go for after E. For example, I would say, okay, I see the patient, the pay for is this one. I see the patient saturation. If no pay for, no problem. You can say saturation is this, and the heart rate is this, respiratory rate is this, no temperature, they're wheezing on the chest. So you can say it's likely patient has the asthma. Okay. After E, you can say that if you feel comfortable. Okay, and then you go for reassessment. But you don't need to hand over. If the patient is still not confirmed it's stabilized, you have to hand over after reassessment, because you will stuck again in a B if they want to test your second line or third line drugs. So you have to be very, very careful when you run this station. Okay, someone ask me a question, please.
In the anaphylaxis, first dose, a second dose of the first assessment, the primary assessment, like this also?
Yeah, in anaphylaxis, I said to you, like you give the first dose in A, for example. I just give you an example. You give first dose in A, then you come up in the C. After breathing, you come up the C. And you found in the C, the patient blood pressure is low. Then you ask if it has 5 minutes passed to first dose. Nurse says yes. Then you go for second dose. Get it?
Okay,
because you guys should ask. The timing is also very important. Where relevant timing is very important. For example, seizing child time is relevant. In anaphylaxis, the first dose should be at least 5 minutes gap. You should ask as to 5 minutes passed, because you need a second intervention and see if the patient is circulatory compromise, low blood pressure. And then you will go for second dose, but you confirm the time has 2 minutes past the first dose, 5 minutes past, she say yes, then go for second dose. But in case your first intervention in C, then your next intervention would be in reassessment. In reassessment, you will stuck long time. Means, for example, if the airway or the circulation is compromised, you give second dose, then confirm again. Confirm again is improve or not, then you go for you will first say, oh, patient has got 2 doses, that means patient is in refractory anaphylaxis, please store the infusion. Okay, then you have to go for that. But you have to stuck on that place until the patient is not stabilized.
Thank you.
All right, so let's come up to the next station. There was somebody who raised the hand just now, so I want to ask him to start it. So our next station is, remember, every station can go to cardiac arrest later on. Every station can go to cardiac arrest, even asthma. So it depends. If I found some candidates are very active, very good, maybe I can make for them the cardiac arrest, because I want they practice in next level. For example, this doctor, the test name, if she did well with the asthma management, maybe I should go to make this station complex when reassessment. For example, if she asks me, is the airway patent? I say no. Patient, I could say the patient is unconscious now. There is no sign of life. Then she can start CPR. So can you tell me what could be the reversible cause for this patient in asthma? When you go for 4HT, so your focus would be what?
Hypoxia.
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 Excellent, guys. Hypoxia. This is very, very important. So these are relevant things. If you don't go for 4H and 4H is a reversible cause, you are doing big mistake. You will lose your score. Anyway, let's come up to the next station. There was the guy is Rafi, and before him there was another guy. I don't know what his name is. Was okay. Anyone can practice, no problem for me. The first guy, if he can, so it's okay.
Hello, good morning. My name is Dr. Rafi, an ED registrar. May I confirm your name and level of competence, please?
I am Katie, and I am a PLS provider.
Katie, could we arrange another member of the team so that we can help in breathing and circulation? And is that be okay with you if you take care airway if you are ALS provider?
Yes, okay.
So we have to receive a 6-month-old baby that is that will be presented to us with the fits. So we have to prepare for that patient. So you will take care of the airway, and so you should arrange the airway trolley, oxygens, and suction, and the other staff will take care of the breathing and circulation and prepare resuscitation trolley and medication trolley, which the medicine should be completed, and we have to calculate for the wet flag as well. Is that be okay? So the patient arrived.
Patient is here, doctor.
Okay. So is the patient fitting now? What is the airway of the patient?
Yeah, patient is seizing now. Mm-hmm.
Okay. So any dose of lorazepam have been given to the child or not?
Yeah, no.
No dose have been given. So according to the wet flag score, so it needs 0.6 milligram of lorazepam. So please give him 0.5 milligram lorazepam.
Doctor is just 1 minute to be a patient is seizing.
So then we have to wait for the patient. What is the airway of the patient?
The airway is patent now.
Okay, so apply high flow oxygen to NRM, and I want to expose the chest and look for any look for respiratory rate. What is the respiratory rate?
Yeah, respiratory rate is 30.
30. And what about the saturation of the patient?
The saturation is 94%.
Okay, and what is the chest expansion of the patient? And what are the auscultation findings?
Yeah, the auscultation is normal. Chest expansion is normal too.
Okay, and what about the capillary fill time now? Since it is spread with A and B, what is the capillary fill time?
Capillary fill time is normal. It's less than 2 seconds.
Pulse and BP of the patient.
Pulse is taky. Blood pressure is normal.
Okay, so I'm pass IV line and take blood from the patient for electrolytes, calcium, magnesium, and full blood count, LFTs, RFTs, and EBGs. How is the patient now? Is the patient still seizing? How much time has been passed?
No, patient is not seizing now.
Okay, and what about the AVPU score of the child?
He's alert.
Is alert. And what about the pupil of the patient now?
Reactive.
Okay, and blood glucose level?
5 millimole.
5 millimole. Okay, I am satisfied with D, so I will go for the C. I will expose the patient from head to toe. Is there any rash on the body?
No.
And what is the temperature of the patient?
39.
Okay, the patient have high temperature, so we have to manage the temperature of the patient. And we have to take care of the hypothermia and hyperthermia of the patient by giving him little bit fluid because the patient is tachycardic. And what about the airway now? Is the patient is okay?
Yeah, airway is patent now.
Okay, so team, we have this patient with the febrile conversion after assessment. So is there anything you have to do for the patient? Is there any plan so that we can discuss as a team?
Doctor, I have a few questions. Is this patient for discharge or admission, and why?
I will keep this patient for observation and will take the opinion of the pediatricians. At this stage, I will call pediatric to come and see the patient for me. This patient I will keep in observation for some time and will counsel her parents about the patient condition, that this is a febrile. Yes.
Yes, doctor. We have the parents here. What do you want to ask them, please?
So I will told the patient that this is a condition that the chances of epilepsy in such type of condition is very low. It is usually around 1%, and but the chances of recurrence is high. The chances of recurrence in such type of patient is 20 to 30%. So the patient can present with the recurrence of the symptoms.
What you will start? When you will start the medication after they start the clock?
If the patient doesn't, if the patient after 15 minutes, if the patient is still seizing, then I will start treatment. Otherwise, I will keep him on oral fluids and to keep the child hydrated and antipyretic on antipyretic.
Okay. Thank you, doctor.
Okay.
All right. Okay. So, what, guys? I'm going to ask you guys a question. This station was like that, but it was not simple seizure. It was complex. Okay, and it can be another. But however, the question I want to ask you guys is to everyone, and can give me answer one by one. Is this patient is for discharge or for the admission, and why? Please do not draw on the board, please. Thank you. On slide. Thank you. Okay. So this patient is for discharge or for admission, guys?
Admission, sir.
Why? Why do you think this patient need admission?
I think this was febrile fits, and patient should be discharged on antipyretic, and keep in the observation. Let the results come, and then if there is nothing, then patient should be discharged with advice. If any fits at home, he should come back.
That's correct. So this patient, you say that the patient didn't require any medication. So it's a simple seizure and stop in 5 minutes, within 5 minutes, right? So this patient need to be discharged, okay? Okay, this is very important, and this is a febrile seizure. It can be cause any infection, can be ongoing any other thing, but it's not very important for us for this station. But important is that we have to differentiate the seizures. Okay, so the next question is what you will ask from the parents and what you will say them. About what? You will take some history, right?
When did it happen? Where did it happen? How did it happen?
Started in history of epilepsy.
Yes. Another. This is
Even
6 months old. So
we have
this
to
is
take,
very.
we have to take event history. When
Yeah,
did
you
it
need
happen?
to.
Where did it happen? How did
Previous
it?
history, epilepsy history, and also the gynecological history. I mean, obs and gynae is relevant, especially to pregnancy, which is about is it preterm or the term? Okay, so these few questions you need to ask. Okay, and then you will talk to them about the fits, which the chance of epilepsy in the future or the fits in the future. You have to advise them. You have to tell them, for example, it's less likely to be in epilepsy, which is very low chance. Okay, but you need to take history first very well. That is the first time, or is the second time, or is the third time? Did he ever had these fits before? So these are very important questions. Another question is when you will start the medication, guys.
After 15 minutes.
After 5 minutes of continuous using.
Yeah, that is correct. But stated epileptics is somewhere we have to go for if the seizure continues 30 minutes without the stop without the over of the seizures, we have to go for the drugs. But in also we have the algorithm which says is 0 to 5, no intervention is usually stop in 5 minutes. If not, then we have to start the first line, which or the benzodiazepine in 10 to 5 to 10 minutes, and then you have to go for second line. All right, and then you will go for the second dose, and then second line, and then third line. So this is how we go for it. So not about the 15 minutes. The doctor, he said after 15 minutes is not correct. It's 5 minutes. Another, I want to correct you. You run the station, okay, but you didn't follow the approach very well. For example, you didn't go with the breathing. You didn't go for first. You should ask about the saturation, then go for the respiratory rate, okay, then further questioning like inspection, palpation.
Dr. Bindi, I have a question here. In second line, we are giving 3 drugs. But mostly we are giving phenytoin and phenobarbital. We are giving phenobarbital in 5 minutes. Why phenytoin in 20 minutes as an infusion? Why not in 5 minutes? Why not rapid?
Actually, we according to NICE guideline, okay. According to NICE guideline, and also if we follow the algorithm, it say or means either you go for the NICE guideline recommend levetiracetam, right? Levetiracetam, not the phenytoin, due to the short and good effect of levetiracetam. That's why we have to go for that drug, not the phenytoin. In children, I'm talking. Another phenobarbital is in case if these both drugs are not suitable, the phenytoin on levetiracetam. So in that case, we go for phenobarbital. for example, if the case is given like that, the patient is already on phenytoin, then we don't have to go for in second line phenytoin, but we will go for phenobarbital. So this is how we go. But there is no any exact like mention you must go with the phenytoin or the phenobarbital. So the guideline recommend about the levetiracetam. Okay, this is very, very important. Any other question?
Dr. B, I have a question.
Yes, what's your question?
In a seizing child, are we going to assess B? Like, are we going to do chest expansion and percussion and respiratory rate if the child is seizing?
It's mentioned the ABCDE. Whatsoever, you have to go for it. And you don't know why the patient is seizing. Okay? Maybe patient is having an infection and the temperature is very high. Maybe that's why he's having seizing. You never know about it. So in emergency, in this case, we always have to go for ABCDE. We must have to go. Otherwise, the station will not make any sense to run it. The seizing must have.
The question?
The question was that, do we need to go for the B, right? This was your question, right? A lady doctor, I think.
Yeah, like in a seizing child, how we are going to do the chest expansion and everything. That was confusing.
If we don't do auscultation, how can we know seizing child can be aspirate?
Yes, very rightly highlighted that the seizing
chest auscultation is a bit different, but I'm asking about chest expansion and percussion, like whole B. Okay, we can do respiratory rate, we can do auscultation, but in a seizing child, are we going to do chest expansion, percussion, or are we going to mention it, or just auscultation is enough?
Whenever you find to mention ABCD, you have to go all the points, okay? Because if while the patient is seizing, but is not about you are in practical life, okay? You are going for the exam, so if it's mentioned that, you have to do. Another thing, you will go for the drugs which you have to give to stop the seizure. Okay, so once you give, maybe the seizure stop, but if it's mentioned, it's no problem. Of course, the mannequin will be not seizing in front of you, right?
Okay, thank you.
Sir, Dr. B, my question to you is, when the patient is seizing, should we put the patient into the left lateral position at that time?
It's not really necessarily.
One question.
It's not necessary. Yeah.
Sir, one question I have.
I want to, let me finish a little bit, and then I will come up to your question. Now listen to me carefully. The seizing child, this kind of station want to test you how you manage the patient. They won't test you the other things. They test you what drugs you will use it, either you are familiar with the algorithm or not. Okay, this is the important point they want to notice. Another thing is about once the patient is stabilized, and they may ask you some question, is I ask you 3 questions, and they have been asked already. So they can do like that. But to put the lateral position, this one, it's not really necessarily, and it's not mentioned in anywhere to do that. Okay, you just have to run the station and be familiar with the algorithm and check the steps. Okay, the important in seizing is the before go for the ABCDE, you need some history, which is very important, since how long the patient is seizing, what medication is giving, is there IV access. If you don't ask this question, you will lose your half-F score, because that will give you the clue how you would run the station. These are very important points. That's why the seizing station is sometimes be complex and can come up in different ways to different people. And this is not the station is running most of other station. Okay, so you have to be very careful. Now someone asked me a question. Yeah, please.
Yes, I have one question. If we have exposed the patient chest, it means that we have inspected the patient, and that's why we can comment on the respiratory rate, chest expansion, and saturation as well.
Sometimes,
is it necessary
sometimes.
to see inspection, palpation, percussion, and auscultation? Though we have gone through it.
I think you guys have totally, some of you guys have totally misunderstood the ASCII stations. I think either you didn't goes very well with my webinar previously, which I already given there recorded. I had mentioned to everyone, first take the intervention, then nurse will take over. Why I say that? Because the ASCII, they want to check your skills. You should do first, then they will follow you. Sometimes, for example, I asked someone during the role play, I asked how to insert the nasopharyngeal airway, because I want to test the candidates what his answer, or how he is going to do, or even he doesn't verbalize. He should show me how he will go for it, because they want to check each and everything, especially your skills. Are you doing this everything every day, or are you doing first time? Of course, when you will do first time, you will be shaking in front of them, and of course you're already under stress when you're in exam. So that would indicate that you are not really professional, or maybe you are not skillful. So that's why what I said, you have to do first, they will take over. I remember I had a station about the NFR access, and I did everything by myself. When I asked them, even they didn't take over, and I run entire station on my own. And this is what can happen to you, the same. Once they take over is good. If they don't take over, you have to go for it. And they want to check you, each and everything, how you do, how you palpate. For example, palpation is what, guys? Tell me, palpation, what's included in palpation? If you watch my webinar previously, you will understand. What mean by palpation, guys? What's included in palpation? Anyone can tell me.
Yes,
in palpation, it included the trachea is central or not, then go for the... Yes.
Yeah, this chest expansion, you will use your two hands to check it is equal expand or not. Also, the trachea central or not with 2 fingers. It's very easy. If you want to run the station when you are very good, for example, CRT, why do you ask? Okay, why? You guys are asking me a question because you are not in live, not face to face. But believe me, if you guys with me in face to face, if you ask me CRT, I will really never answer you. I would say you are not practical. You don't have any practical skill, because you're not going for the CRT. Use your 2 finger on the sternum and then check it by yourself. When you will do that, then I will say CRT is less than 2 or greater than 2. Did you get my point? In the exam, you don't need to stand and you ask the nurse, what is the CRT? She will not answer you. She will even answer you, but she will consider you are not professional. That's why I've written everything, and you guys are forgetting important things. My previous webinar, I thought you already went it and you guys got it. What I want to say, that first you do, okay, they will take over. When you palpate the chest, when you try to focus on how to measure this one, the trachea, and with 3 fingers, you just put the middle finger is in between or not. When you put it, and then the nurse will say, yeah, trachea central. If you don't do it, you will ask her just. That doesn't make sense. Palpation you have to do by yourself. Percussion you just quickly do. with your finger, and they will say that you are doing correct. When you just do one time once, they will tell you percussion is normal, or there is abnormalities. They will mention you when you put the stethoscope on the chest, and they will say auscultation is normal, echo, the lung sound is normal. And when for the cardiac, for circulation, and if we want to hear the murmur, then when you put the stethoscope, they will tell you there is a murmur. So this is how you run the station. But if you think like that, you will just like a Superman stand in front of them and you will just verbalize, say every time. That doesn't make sense. You will take over, you will do it, your leader also, but you will do by yourself. For example, anaphylaxis. Now you got the patient has the rash all around the body. You come up the head of the patient and you will ask a nurse, is patient talking? Is the patient conscious? Is a conscious patient talking or not? Then she say unconscious, or patient is talking. Yeah, patient is talking right now. Or she will say patient is alert. Then you will open the airway. Then you will check it out, the airway patent or not. Then when you will touch the mouth or the chin, she will say the patient has swollen tongue and swollen lip. That means the airway is compromised, and you will go for the nasopharyngeal. Nasopharyngeal will be there, and you just pick up and insert it. And she will check you out, did you insert the correctly or incorrect? That's very important. You measure the size and then you will insert. And everything, they will check you out. If you verbalize it, that doesn't make sense. When you will say to her, please insert the NPA, the nurse will ask you how to do. That means she wants you to do. Take the NPA, measure the size, and then you insert. Okay? When you will verbalize and do the practical, you will get the score, highest score. In that case, you will get it. If you just verbalize, don't take over, just you stand like a Superman, of course you will lose your score. Unless the nurse say to you to stay here, you just verbal, we will do, that's good. Overall, nurse always do like that. When you take first you do, they will take over. For example, a patient came to me, was in cardiac arrest. I started the CPR, I put my hand, nurse say, I'm going to here, please, what need to take it? What intervention further? She said to me like that. And that means she took over the CPR, she is doing CPR, and I'm going for, while she is doing for 2 minutes CPR, I'm going for 4HN40, I verbalize, and I tell the finding. This is how the station was running. Clear so far?
Yes, sir. Excellent.
Yes, that I want you should understand that. That's why I said resus need face-to-face. Resus need face-to-face. Examination need face-to-face. You should do practice. Your brother, any family member sitting, lying on the bed or any sofa, you just do it. Go, knock the door, come inside, introduce yourself, nurse, just verbalize and do, action. All the time take action, and you will be master. This is what I want from you guys. This is not a big deal what you are saying. It's a good thing. It's help you to understand these all things. You are joining the webinar, you are practicing. That's one thing is good, but you are not doing practically. This is the drawback. And hopefully in the future, you will have the everything in live, face-to-face, and you will perform, and I will be next to you. This will be in some time later. All right, let's move on to the same station we are going to do. Who wants to do this station again? Because I want to make it a bit complex. Anyone? No one? Okay, I wanted. All right, thank you.
Hello, sister. I am Dr. X. May I know your name and level, please?
I'm Katie. I am the senior nurse.
Okay. Are you provide AL strength?
Yeah, I provide APLs.
Please, sister, take the airway trolley. prepare oral truly and difficult difficult oral truly and Sister B, please, for
Okay.
circulation and call a resource team and alert the pediatric team and wash my PPE. Patient here?
Okay. Yeah, patient is arrived here.
Okay. What about the ABO score? Patient is alert?
The patient is unconscious in the response to pain.
Okay. Well, what about the airway?
Airway is patent.
Okay. Please give oxygen 15 liter by number breather mask. I will go to the B. What about the blood pressure? What about the SpO2? Sorry, to the breathing.
Yeah, the SpO2 is 92%.
92.
Yeah.
Okay. What about the RR?
Respiratory rate is 25.
Okay. What about the trachea?
Trachea is central.
What about the neck pain?
They are not visible. They're okay.
Okay. By inspection in abnormality in the chest.
The inspection is normal.
By palpation.
You have to do.
By palpation. Any abnormalities?
Yeah. Palpation, you ask me trachea central. Yeah, it's central. Chest expansion is normal.
By percussion?
Percussion is normal.
By auscultation?
Auscultation is normal.
Okay. I am going to the blood pressure. What about the blood pressure circulation?
The blood pressure is the 60 by 40.
What about the CRT?
CRT is 7.
What about the pulse and rhythm?
It's 130.
Okay. Rhythm?
The heart rate, sinus tachycardia.
Okay. Please call the pediatric team and take investigation, full blood count, biochemistry and lactate and VBG. Okay, and give 10 ml of saline according to 10 according to wet flag. 10 milligram per kilogram according to wet flag. Meanwhile, to go to the disability. What about the ABCO score?
Patient responsive to pain.
Okay, what about inner lateralization?
No.
What about blood glucose?
Is 3.8 millimole.
Okay, what about exposure? What about temperature?
Temperature is 38.8.
Okay, any rash?
Yeah, patient has a rash in lower limb.
Okay, this most likely it is meningococcal septicemia. Please give paracetamol for this. I will reassess pediatric team. It is arrived.
Not yet.
What about the airway?
Airway is patent.
What about the breathing? SpO2?
92% on high flow oxygen.
Okay. What about circulation? Blood pressure?
Blood pressure is 90 by 60.
90 over 60. What about the CRT?
CRT is still same.
Okay, any result?
Yeah, we have a blood results. What do you want to know about?
What about the pH?
pH is acidosis.
What about the bicarb?
Bicarb is 15.
Okay, lactate, any result?
Yeah, lactate is around 18 millimole.
Okay, this patient most likely you have meningococcal septicemia. Please start give antibiotic, ceftriaxone, 80 milligram per kilogram according to wet flag, and keep patient in oxygen.
Okay.
And continue the fluid. This patient need in the isolation room.
Okay.
Pediatric ICU scan arrive.
Yeah.
This I have a patient with drowsy, came by ambulance is drowsy and is feverish and having rash, most likely in the lower limb, most likely having meningococcal septicemia. I put start medication and I put in the isolation, endorse the sister to give in the isolation room.
Okay,
This
thank you.
patient with acidosis.
Okay, thank you. All right, you did a great job, but your antibiotics, and you already said meningococcal septicemia without going for lactate level or the asking blood result after E, which is totally wrong. Okay, so you should take the blood result. Well, first you go for shorter breathing. It's like that. The patient is the drowsy came into ED, and the temperature is high and the blood pressure is low. Saturation is maintained on 92% on high flow oxygen. So, and so do we have the blood result now? Okay, yeah, okay. I want to know about the lactate. So I said if I tell you is more than 2, which is supposed to be less than 2, and in that case you will say, okay, it's elevated lactate level, and also these features, it suggests that patient has meningococcal septicemia, but you have to mention the rash and lower leg. So these are all things that you need to mention, and then you go for reassessment. All right.
Okay. Okay.
But you ask me lactate level in reassessment. If you ask me the lactate level everything in after A, then reassessment goes smoothly and just hand over. That's it. Clear? And you know the patient cannot be improved suddenly with that. The CRT is still okay. The blood pressure is nearly borderline, is the 90/60, which is not really good at all. So still patient need intervention and need ICU admission, right? So it doesn't make sense that you suspect the patient will be improved. No, patient will be not improved, except patient. Okay?
Okay, okay.
Yeah, so your intervention in sepsis, if antibiotics is going the after A and the 80 the mg per kg, you can store it antibiotics, okay? And septoxemy is useful in children. All right, that's good job. I think I'm taking a lot of time, so let's move on. Anyone who want to practice next session, guys? Anyone? No one?
Yes, I can do it.
Okay. You want to read it first, right?
Yes.
Okay. Okay.
Hello, good morning. My name is Dr. Rafi and AD Registrar. May I confirm your name and level of competence, please?
I am Katie and I'm APLS provider.
Okay, nice to meet you, Casey. So we have to receive a 1-year-old child who will arrive in a short time. So we will be in need of other staff as well. So is that be okay if you can take care of the airway and the other staff will take care of the breathing and circulation?
Okay.
Okay, so you please prepare the airway trolley, suction and oxygen, and the other staff will prepare the medication trolley and resuscitation trolley. And we have to calculate doses of different drugs according to the wet flakes, and we have to involve the resuscitation team for our help. Make sure we have in proper PPE. Is the patient arrived?
Patient is here.
So I have to take a brief history from the in charge nurse again. So what about the patient airway?
Airway is patent.
Okay, so apply high flow oxygen through NRM at the rate of 15 liter per minute. Now I want to expose the chest and please attach monitor with ECG electrodes, pulse and NIV BP. And I have to look for the trachea, where the trachea is central and the neck veins. And then
Trachea central.
Okay, what about the respiratory rate?
Respiratory rate is 30.
And saturation?
Saturation is 94% on oxygen.
Okay, and chest expansion?
Chest expansion is normal.
Okay, I will check inspection findings, palpation and percussion, as well as auscultation findings.
Yeah, the trachea is central and the percussion is normal. Auscultation is normal.
Okay, so I am satisfied with B. Now I will move to the C part. What is the capillary fill time?
Capillary fill time is 7.
And okay, and what about the pulse?
Pulses, the in front of you is 239.
239, and so the pulse is increased. And what about the BP of the patient?
Is 50 by 40.
50, so the patient is in shock. So we have to give shock to the patient. So prepare defibrillator, attach defibrillator pad, and we have to give according to the wet flag the synchronized shock to the patient.
How
And,
joules? How energy, doctor?
4 joule per kg body weight. So we have this 1 year child, so 1 into 2 plus, so it will be 9, and 9 35. So we need 35 joules for this patient. So everyone clear? I am giving shock to the patient.
Shock given.
Shock given. Now I have to check the pulse and rhythm of the patient. What is the rhythm and pulse?
It's still same.
Same. Then I have to give another shock to the patient.
Okay.
Everyone
Shock
clear?
given.
Shock given. Rhythm,
Given.
check the rhythm and pulse again.
It's the same.
So I have to give another shock for the patient. Everyone clear? Me clear? Everyone clear?
Third shock given.
Third shock given. How is the rhythm and pulse?
Patient unresponsive now.
So I have to start the CPR. And what is the rhythm is the same?
Yeah, it's just non-shockable.
non-shockable rhythm. So we have to give, it is pulseless electrical activity. So we have to start CPR and give epinephrine according to the wet flag score. The patient have 1 year old, and we have to give adrenaline 0.1 ml per kg body weight, 1 into 10,000.
Okay.
Given, and we have to start CPR again. CPR for 2 minutes. We have to start CPR for 2 minutes, and we have to look for the 4H and 4Ts. What is the temperature of the patient?
Temperature is normal.
And what about the, is there any hypovolemia? We have to pass IV line, and we have to send blood from the patient. We have to involve the ICU team as well, because the patient is unconscious and we may be in need of ETT.
Okay, doctor, 2 minutes passed.
Okay, so 2 minutes pass. What is the rhythm and pulse?
Sinus rhythm now. Patient has pulse now.
Okay, congratulations, guys. We have achieved the RAS. We have to involve the ICU team as well. What about the 12 lead ECG?
Yeah, it's sinus.
Okay, well done. And what is the airway of the patient now?
Airway is patent.
Okay, and what about the B?
Saturation is normal, 94%.
Okay, and what about the blood pressure?
Blood pressure is improved on 10/60.
Okay, well done. And what about the GCS of the patient?
Patient is alert.
Well done, great. We have to thank you, guys. We have achieved the SAS. We have to involve the intensive care unit, and we have to do 12 lead ECG, and we have to maintain the patient temperature from 32 to 34.
All right.
Okay, thank you very much.
Thank you. Guys, what is the energy joule? Anyone can tell me in SV for SVT?
Yes.
Yeah.
Yes. It should be 1 joule per kg. Initial joule, 1 joule per kg in synchronized shock.
Yeah.
So,
Dr. Rafi, is not about the age, it's about the weight. Okay. Weight is very important, not the age. Okay. First shock should be 1 joule per kg. Second, increase to 2 joule, like that way. And first is that one. And about the adrenaline dose is also according to weight, 0.1 ml per kg, not according to the age. Okay, that's, you should be very careful.
No.
Another.
Sir, one thing. I have calculated according to the 1 year age, 1 into 2 plus 8, so it's 9 kg. 9 kg, that's why I have calculated like that. According to the formula from 1 to 10, we have to use 1 into 2 plus 8. I have calculated through the web, but I have missed the dose of the synchronized shock.
It's okay, no problem. But you just need to mention 1 joule per kg. That's okay. It's not necessarily you need to think too much. All right. Okay, let's come up to the next is about I make this station to cardiac arrest. Usually the ORCAM make the station in cardiac arrest once you go very well. Another important thing, if patient is conscious, then you have to give the sedation. Okay, patient requires sedation for the shock. Okay, don't go for it. And the shock if the child went to cardiac arrest, in that case 4 joule per kg. That's very important, and that is synchronized. That's very important. They want to test you as well. 4H and 4Ts here, you need to go for PAX here, hypovolemia. You have to go for hypothermia. You also need to go for the hyperkalemia, hypohypokalemia. Okay, so and then for Ts, this is very important, toxin, etc. Okay, so you need to be very, very careful.
I have one question here. If we are asking for sedation and if we don't have IV line, then how to give the sedation?
You mean you are asking about the sedation, conscious sedation,
for
right?
For cardioversion, yes. For cardioversion, if we are asking, because without if no IV line, then how to give?
Now you tell me, before you go for intervention, what you have to do.
Yes. If
What you have to
IV.
do. I mean, I'm talking about say before you go for intervention, what you do.
Because in pediatrics we have read that we can give intranasal ketamine if we don't have IV line.
Yes,
For
you can
sedation.
give. You can also that way. It's also you want to go for intranasal, and also you can go for the midazolam can be give buccal as well. It's not a big deal. But I'm asking you what you do before you go for the sedation, for example, intervention.
We have to get the IVXX, then go for
Yes.
the.
No, I am asking if we are unsuccessful. If we are unsuccessful to take the IV line.
If you are going to,
if there is any delay in IV line.
Yeah, then no problem. Then you can go for the intranasal. If it's mentioned that ketamine, so you have to go for it. But overall, there will be no issue. Usually we go for the investigation first and then go for intervention, right? So if not given, for example, if the IV access is given, I mean, you go for the investigation, then you have to go for the sedative drugs, which we commonly use for that or the conscious sedation for the cardioversion. Okay, if the patient is conscious, but in unconscious, we don't have to. But for this case, I give the unconscious. Didn't you get it?
No.
No, you didn't get it. Okay. I mean, is that I would say usually we take the investigation before we go for intervention, right? We ask one nurse to take the IV line to extract blood, blah, blah, and then we go for the intervention, like either we go give the drugs or we go for the shock, okay? So it depends. So in your case, you are asking about like, if we don't have IV access, then we have to go for IO access. If we don't take both of them, then intranasal ketamine. Did you get my point now?
Yes, I have gotten your point. But actually, my question was, if we are not reach on IV and patient went into supraventricular tachycardia and we don't have IV line, then what should we do?
We don't have IV line, then IO access.
Yes, because patient can anytime patient can go into the SVT, unstable SVT.
Yes,
so,
yes.
Until unless we take the IV line, we have to give intranasal because we have to give shock.
Yes, that's correct. If you don't have IV access or IO access already, so you have to go for the intranasal. But I was talking about in C, when you are going for intervention, first you go for investigation.
Yes,
yes,
that's correct.
right?
No,
so yeah, so in case if you are not going to take it, right, and you are having difficulty and you need to stabilize the patient, yeah, then you have to go for the intranasal ketamine. Of course, you have to go anyway to give the shock to the patient and to stabilize. Yeah. So these are the intervention, but I just want to say that we do before, we always do intervention after investigation. Say, anyway, no problem. You can go intranasal. Okay, so next station we are going for it, and who wants to practice? I think this station was straightforward. I don't think so. You will have bradycardia, so I haven't ate it, and it's not even very important. Okay, so we have the next station. Who wants to practice?
Okay, I will practice.
You ready?
Yes. I am Dr. Mustafa Emergency Registrar. May I know your name and level?
I'm Katie, and I am APLS provider.
Okay, thank you. Please prepare. You care about the airway. I need to prepare the airway and fortificate airway trolley. And please prepare the circulation and alert the pediatric team and wear the PPE.
Okay.
I suspected one patient with 4 days came with ambulance.
Okay.
Patient is alert.
Your patient is unconscious.
Okay. What about the airway?
Airway is patent.
Okay, please apply oxygen 15 liter by 9 degrees on mask. I will go to the breathing. What about the SpO2?
The oxygen is 80%.
Oxygen 80%. Okay. What about the RR?
Respiratory rate is 30.
Okay, what about the trachea?
Trachea is central.
Okay. What about the neck vein?
Neck veins are okay, normal.
Okay. What about inspection in abnormality of the chest?
No.
By percussion in abnormality?
Normal.
By auscultation?
Yeah, on auscultation of what? Lung sounds?
Auscultation of the lung?
Lungs are clear.
The heart, so okay, the heart, no problem.
The heart is murmur here, the systolic murmur.
Okay, please maintain oxygen between 75 to 85 and call to the cardiology. I need also X-ray and ECG. What about the blood pressure?
The blood pressure patient is 90 by the 70 by 30.
Okay, what about the CRT?
7.
What about pulse for brachial and femoral pulse?
The pulse is I cannot feel the pulse in the lower limb. Yeah.
Okay, in the brachial.
There is.
Okay. This patient, if showing shock, please give 10 ml. Please call the cardiology and pediatric team. Patient in shock, give 10 ml normal saline according to with flag, and take full investigation, full blood count, toxicology, chemistry, and lactate. I will go. Meanwhile, go to the disability. What about the patient is alert? If you
The
score.
patient responsive to pain.
What about the blood glucose?
It's 5 millimole.
Okay. What about the temperature? Or go for E.
Normal.
What about the skin? Any rash?
No rash, but patient is pale.
Okay. Any result?
And clammy. Result of what?
Result of VBG?
VBG?
Yes.
Okay. What do you want to know?
I need the pH and bicarb and lactate.
Lactate is normal.
Cardiac arrive?
Yeah, team arrive.
Okay, I have patient 4 days, came by ambulance. There is murmur and absent pulse in the lower limb. I need echo and cardiac catheterization, most likely congenital heart disease.
Okay.
This patient
All right.
For care for you.
Okay. Thank you.
Thank you.
Well, you did good, but you didn't tell about the defect.
Doctor?
You did very well, but you didn't tell about the defects. Is congenital heart defect, okay? First. Second is about the chest X-ray you order, your AVG you order, but you forget to order the echocardiogram.
Echocardiography. Okay. This for for indoors.
I know it's for the indoors, but you need to just verbalize. I record to get the echocardiogram if cardiogram is possible. So what happened when you come after the A? Then you have to verbalize the finding. First is that this child is the baby is 4 days old. Okay. Second, the absence of pulse. Third is pale, claiming in shock. So it's likely the patient is having the heart defect. If you want to be specific, it can be court action of aorta. Okay. So this patient required the cardiology admission. Okay. And the further intervention will be taken. But one thing you need to mention, it can be prostaglandin to help. Okay. To store the prostaglandin infusion for now, this patient required. So my meaning is that you didn't verbalize first the finding in the likely diagnosis after E. First. Second is about the investigation, which you ask about the lactic level, which is not relevant because is 4 day old, so it's likely be heart defect. And inside you ask that, you're supposed to ask about chest X-ray. Okay, and you can, yeah. So this way can help you. And I made it quite action of aorta, but you can have in other anomalies like the transposition of great arteries, the tetralogy of Fowler, all these can be possible. All right. Okay. Let's move to the next station. Actually, this is very simple station and just need to verbalize about the defect and catch the diagnosis. Let's go for next is who wants to try? This is going to be a second last station. Anyone who wants to try this station, this is very important and it came in previously in the exam.
I will do it.
Okay.
Okay, this is neonatal resuscitation. Okay, I start.
Okay.
Good morning, I'm Dr. Riyad. May I know your name and your level, please?
I'm Katie and I am APL's provider, NLS provider.
Okay, Katie, are you happy to take care of airway and difficult airway intubation for neonate?
Okay.
Okay. And what's your name, please?
Yeah, I'm Katie.
Only one nurse, okay. And you will be also allocated for...
Two nurses. Another is...
Two.
Yeah, two nurses here.
Okay, the second nurse, you will be allocated for circulation, IV access, cardiac monitor, and IV and drug. Is that okay?
Okay.
Okay, we need also to alert the pediatrics, prepare our wet flag. So watch hand and PPE. The patient is here.
Yeah, baby's here.
Baby here. Hello, baby. Any response from the baby? No response?
Baby newborn.
Newborn, okay. So we need to calculate we need we need to delay clamping the cord and two towel drop the two towel. One towel is for drying and one towel is to cover the baby, and we need to keep him warm, and we need to start also the clock. Okay, so then we need to assess the Apgar score. Here for this case, what about activity?
Activity is baby is
Baby.
weak cry.
Weak cry. So respiration.
Respiration
Yes.
is normal.
Appearance.
Appearance is sinused.
Okay. So this is severe depressed Apgar score. We need to
You should go for activity is floppy. Okay. The heart rate is less than 100 and appearance is sinused peripherally.
Yes.
And
So,
respiration is slow and irregular.
Okay, we need to start giving him 5 insufflation breath. And please, Kathy, apply monitor and need 3D DCG and SpO2. Is that okay? And we do that for after 5 inflation of any change in heart activity?
After inflation, there is expansion of chest.
And what about heart rate?
Heart rate is still low.
Okay,
less than
Kathy.
60.
Okay, Kathy, put towel behind his shoulder, and we need to maintain breathing with 2% technique and repeat inflation, but this time we need to increase the pressure of airway. Is that okay? Any anesthesia is available, because we need to consider intubation for this baby, and we need to protect his airway. So we give 5 more resuscitation breath. Any change in heart rate? Any and what about chest movement?
Chest is moved, but there is no improvement in the heart rate. It's still low.
Okay. So here if and we need to give
30 ventilation.
Ventilation for 30 seconds, 1 breath every 1 second, and we reassess after 30 seconds. So what about 30 seconds?
30 seconds. Yes, passed. It's still saying low heart rate.
Okay. So here we need to start CPR, 3 compression, 1 ventilation, and we need to increase oxygen to 100%. And is neonatologist here because we need to intubate patient, and we continue this for 30 seconds, and we alternate for each cycle of 30 seconds.
Doctor, how to do CPR?
Okay, we need to with 2 fingers we encircle the chest, and at the level of
Stern.
nipple, yes,
Okay.
at the level nipple, and 2-finger technique. And
Okay.
yes.
30 seconds passed.
Okay, and this is a problem. This is considered cardiac arrest. So we need to nurse see. Please get umbilical IV access, and we need to give him adrenaline as per with flag, and we need to rule. Look for 4H and 4T. Here, most probably, it's hypoxemia or hypovolemia. Hypoxemia may be probably caused by congenital abnormality. It can be heart congenitally, it can lung congenitally. Abnormality. It can be congenital hernia deviation, the abnormality. Also, for hypovolemia, we need to give him fluid resuscitation as per wet flag, and for the other causes like hyper or hyperkalemia, we need to also get blood investigation for hematology, biochemistry, VPG, lactate, and to rule out cause of hyper or hypokalemia. So for the traumatic case, they are less very not can be excluded here. So still toxin, maybe the mother has problem with this drug adduct, so we need to ask about the past medical of the mother. And what about pupil for the baby?
Your reactive?
Reactive, no, there is no meiosis. So we the neonatologist is here.
Yeah, after giving the adrenaline, patient is okay now.
Okay, good.
Patient improved.
Yes, good.
Yes. Reassess.
Okay, we need to reassess. What about airway now?
Patent.
A patent?
Mm-hmm.
What about
Patent.
breathing? What about SpO2?
94%.
What about respirate?
Normal.
What
30.
about blood pressure? What about blood pressure?
Improved.
What about capillary refill time?
Normal.
So what about Apgar score now?
The peripheral Apgar score, you have to take it. Now you have to assess it. And the Apgar score is now the patient has still the sinus in a periphery only.
Okay. So sinus in periphery. So this patient obviously need to be intubated, and we need to request him cardiac echography. And
patient hand
yes.
over to neonatologist. Okay. Now listen to me. You did very well, but you need to be very fast, fluent in communication. The important thing I want after adrenaline, you need to confirm, is the heart rate improved? I should say yes. That means the patient is improved, right? Then go for handover. In case if you ask me here, I should say yes, the ICT neonatal NICU team is here and you have to hand over the patient. Okay, so the one more important thing which I want to mention here is that the umbilical access, yeah, you did very well about it, and you have ruled out the causes, and you did very well, but you must confirm the adrenaline after that heart rate improved. Then you reassess A, B, C, D, E again. Another important point just now came to my mind, but I cannot memorize. Any other important point? What he forget it, guys? Could you please help me to find out? Anyone?
In the beginning, he forgot to start the clock and put the baby in the radiant warmer.
Yes, that's correct. Another important.
Another important thing.
Put the baby in the neutral position.
Okay, good. Another?
Did not arrange the suction machine and the proper size of the face mask for the child.
No, it's not relevant. It's not very
After the
important.
5 inflation breath, if there is no chest rise, then he should ask for the 2% technique of the.
Yeah. But I already said the chest will expand. Okay. Now I want to ask you 3 questions from 2 questions from this doctor. I don't know what his name. My first question is no, I forget one important point. I think you guys also forget it. What was the important point I just now came into my mind and I cannot memorize again? It was very important. Anyway, let me ask you a few questions because once you're done, the nurse can ask you a few questions. First is like, what would be the compression rate?
3 to 1.
3 to 1.
3 to 1. That's correct. And another was about 3 to 1. That's correct. Apgar score, very important. What is the initial Apgar score? I give you the important points. Did you get it? What was the Apgar score? I said the baby sinus peripherally, we cry, and I also say about the respiration irregular, baby is floppy. So what could be the point? How much is score?
4.
4. And what about in the end when I say there is sinus peripheral? Did you tell me the Apgar score? What
In the
was?
periphery? When the periphery is the blue?
Yes, only.
Only the periphery score is 1.
Uh-huh.
And if the heart rate is less than 100, then the other
Score is not 1 actually. Okay. Total score is how much, guys?
10.
10. And only you finding is peripheral sinus. So what would be the score?
9 out of 10.
9 out of 10.
9 out of 10. That's what I want to hear from you.
Okay.
9 out of 10 after resuscitation. Okay. So do you think so, patient, you still need to continue resuscitation or you have to hand over?
Hand over.
You don't need to continue resuscitating. I think so. This doctor was trying to continue further, which is not right. Okay, because the normal. What is the normal Apgar score? What could be considered normal?
8 by 10.
Between 7 to 10.
Above 7 is considered normal. 7 or above 7.
7, 9, 10. Okay, these all to be considered normal. So it's already almost going to be normal. So you don't have to. It's normal. So you don't have to go further. And hand over. That's it. Okay, if when you come up to the airway, if I said airway is not patent, then you can ask me a question. Is there any secretion, any other stuff there, like mechanism? Then I say yes, then you have to suction and remove it. And then ask, how about the airway now? Is patent or not? But I didn't make it, I just say it's patent. So overall, you did very good. I think you did a great job, but you need to be more fluent and you have to be very, very careful with the listening, especially when as the chest is already expanded, then you have to move for ventilation. You don't have to go for again that. And once another important in Apgar score, once I tell you the points you need to pick up, and there was 6 before, and then you got it, the patient is going to have 9, so you have to mention. So this question you can get in the during the exam. Means once you finish a station, stabilize, the nurse can ask you this question. You should be ready for it. Okay, let's go to the next station. We are going to have final station for today. Is this one? The second last, I think. It's still one more station. Okay. Okay, who wants to do that? Anyone?
If no anybody, I will.
I
All
will do
right.
it if no problem.
Any of you guys can do it, no problem. Yeah.
Okay. Who will go?
Okay.
Okay. Good morning. I'm Dr. Riyad. May I know your name and your level, please?
I am Katie, and I am APLS provider.
Nice to meet you, Katie. Are you happy to take care of airway, please? And difficult airway trolley?
Okay.
Okay, and nurse C, what's your name?
I'm Casey.
I need another nurse for circulation.
Okay, nurse B, Casey.
Okay. Okay. So are you happy to take care of IV access and monitor and drug? And we need to prepare with flag here. We are expecting a patient 3 years old, and he's drowsy, and here we are suspecting group, so we need to know to prepare adrenaline. And we need to also prepare dexamethasone. So is the baby here?
Yeah, baby's here. The child is here, right?
Okay. Hello, baby. Hello, baby. Is the baby responsive?
Baby is alert.
Alert. Okay, great. So is airway patent?
The airway, baby is cough sometimes. Yeah, it's airway is patent.
No secretion. No secretion.
No secretion.
No swelling. No tongue. No tongue. No swelling. No lips swelling.
No, nothing. He has harsh cough. Occasional.
Okay. Okay. So Katie, please apply high flow oxygen and attach monitor. Expose the chest, attach monitor, and we need to have attach 3 lead ECG and SpO2, and we need to have what about auto saturation?
Saturation is 91%.
91%. What about respiratory rate?
Respiratory rate is 35.
35. Okay, great. What about trachea central?
Trachea central.
What about neck vein?
Normal.
What about chest expansion? Any abnormality in the chest expansion?
Normal.
What about chest palpation? Is it bilateral chest expansion?
You ask about it. Palpation is normal.
Yeah. No. Okay, good, great. What about percussion?
Normal.
Okay, what about lung auscultation 6 point?
That's normal.
What about heart auscultation, heart sound auscultation?
Normal.
Oh, great. So, Katie, we need to move to circulation, and we need to obtain now vital sign. What about blood pressure?
110/60.
110/60. What about capillary fill type?
Is 2.
So it's normal. Okay. So what about heart rate?
Tachy.
How much?
110.
110. Okay. So okay. So what about skin swarms? Is it called clammy motor?
No, normal.
Normal, okay. So, Kathy, we need to obtain here IV access to IV access, and we need to the point is group يعني here. For ECG attached, what about cardiac rhythm?
What? CRP?
No, on ECG there is any abnormality?
No.
Okay. So this baby is probably we continue for our examination. What about GCS or AVPU for this baby child?
Child
Is alert,
AVP
right?
is alert.
Alert. Okay, great. So his pupil. What about pupil?
Equirective.
Correct. What about any sign of lateralization?
No.
So what about blood sugar?
Normal.
Exposure. What about exposure? Any rash? Any abnormality?
No rash.
What about temperature?
Temperature is 38.6.
Okay. So here I'm suspecting here for this child a group. So I need to give him dexamethasone 0.15 milligram per kg. So for his he's 3 years old. So he will be 3 by 2, 6 plus 8, 14. So we give him 0.15 milligram dexamethasone, and we'll reassess. We need also to establish his Wesley score. So there was no stridor, right?
There was harsh cough. Yeah, Strider. Yeah, Strider is there.
Stridor is there. So we need to give him
Saturation is less than 92%, and Strider is a harsh cough. So what is the Wesley score?
So saturation at 92 is 4. Harsh cough. Stridor when agitated or at rest?
At rest.
Stridor. At rest. So 4 and 2 is 6. And cough, there is no cough on Abgas score.
Yeah.
So it's 6. 6 here. 6 is severe, so we need to give him 1 dose of dexamethasone, 0.15 milligram, and we need to give him nebulizer adrenaline, 0.5 ml, 1/1000, maximum dose which will be 5 milliliter, and we need to after that we need to reassess the patient and
Let's reassess the patient now.
Yes. So what about airway? Is it patent?
Here is patent.
Okay, no secretion.
Strider is improved.
Okay, and oxygen is going on, right?
It's 94% now on high flow.
94. Okay.
Yes.
What about respiratory rate?
Respiratory rate is 25.
25. What about blood pressure?
Blood pressure is normal.
What about capillary field?
Normal.
What about IVPU is alert?
Alert.
Okay. What about pupil?
Ecoreactor.
What about any sign of lateralization?
No.
What about blood glucose?
Normal.
What about exposure, temperature?
Temperature is 38.6.
38.6. So, and what about any rash, any skin rash?
No.
So, any handover available?
Yeah.
So, we have three. Good morning, I'm Dr. Riyad, ET register. We receive a child, 3 years old, complaining of
handover.
Yes, complaining
Okay.
of drowsy and yes.
Okay, thank you.
Welcome.
Okay, when you ask about the airway, I say harsh curve. Okay, no problem. Okay, if you don't consider stride, or I added later on, but what is the Wesley score, guys? Is what would be severity of this croup? Is severe or the moderate?
Severe.
Everyone.
Moderate.
Severe. 6 to
Severe more
11.
than 7.
Severe is 3 to 5. Here, severe because moderate 3 to 5. Mild 0 to 2. Severe 6 to 11.
Yes. Okay. First is that I give you already saturation low. That's also indicate to you this is going to be the severe. Okay. And the saturation low, but it doesn't mean that you must have the strider. Okay. It's not necessarily. If have is okay, if don't have, no problem, but still you can suspect it. So what you have to do in the E, you have to verbalize the finding. So this patient is 15 and his cough is mentioned there. And I also said it's a harsh cough he has it. So that's indicate the age is 15 months and also the patient has a cough and you find saturation is low. All right. So these all indicate that the patient is going to have croup. And then you have to also go for you also need to tell the differential. Say in the UK, the bacterial epiglottitis is less common, so it's not really possible, and it's severe. The usually patient present with severe form, so it's less likely here. And the Wesley score for this patient would be blah blah, and it's a severe case. So I want to prescribe, or I want to ask a nurse, just say I want to prescribe the adrenaline to nebulize this patient with the adrenaline blah blah, and also the DEXA 0.15 mg per kg. So you have to verbalize that. And then you will go for reassessment. Then you will go for ABCD, but you don't need to go like each and everything like the trachecentral. No, you just go for the airway patent. Patient is alert, right? Then you go for the oxygen saturation. Then you will go for the heart rate, okay, blood pressure if possible. Then you will go for the ND. They ask about the glucose level or say GCS or upper score, AVP, and then in the end you will go for the temperature. That's it. So make very short in reassessment, but could be very long in. But you did very well in the end. You're breathing, but you need to aid the points. Points, and when you think about suspicion of the differential, you also need to aid the differential diagnosis that it's less likely in the UK epiglottitis, so more likely could be croup. And if to follow the croup score, the score would be blah blah. So then you take intervention. I prescribe adrenaline, nebulization, blah, blah, blah. And also the Dexter 0.15 milligram per kg. Okay, that's great. So it's not necessarily that in the exam you must focus on stridor. No, it's not secretion. Sometimes they won't tell you, because if they tell you everything, so what could be? So that station is straightforward, right? So you should be. So you should be ready every kind of scenario, and you must know how to take out the score. You guys are doing big mistake that you don't taking a lot of time to take the score. Scores are very important, and that make you perfect. It's a similar way in newborn. You guys are missing the Apgar score, which is very, very important, because if you don't take the Apgar score, how could you go for intervention? Intervention requires, when if it's less than 7, it could be 5 or 4. But if you don't know how to take the Apgar score, how you will go for intervention? For what reason you are going for it? So this is very important. You guys are doing very wrong when you just say, I will go for Apgar score. Now I'm going do, blah, blah. No. First you take out the Apgar score, and then when you will mention how about the activity, how about the stimulation, baby's crying or not, the nurse will give you answer. And through this way, you can get the Apgar score. And sometimes they do ask you what is the maximum Apgar score. So you should know it's 10. Okay. Let's go for the final
Yes,
step.
doctor.
Yeah.
One question, doctor. Can I start first the dexamethasone from the first in the airway from the beginning?
Look, the things are not very clear, right? Things are not very, very clear. Either it's a croup or epiglottitis. You don't know. You guess it from the age it could be, but you still don't know.
Okay. This start after at the E.
If stridor is mentioned, if they mention the harsh cough, if you see the age, that would make sense. You go for the beginning, because if the stridor is likely be absent and somehow the sounds is not very, very clear in epiglottitis, and patient present to you very severe case, okay, in bacterial infection. However, it's very less common, but it can be possible if they mention you the baby is recently immigrant to UK, so that can give you idea that it can goes to epiglottitis. Okay, so you should be very careful. If you think so, if I give you option like, yeah, there is a stridor, then you can go for Dexa 0.15 milligram. But I would say would be better if you verbalize, go for all finding, take the Wesley score, okay, and then you start the intervention. That would is more appropriate and would be much better to go for initial intervention. Clear so far?
Okay.
Because when you go in the end, the things will be very clear to you that what could be, but in the beginning it's not very clear. Another important thing, you guys are forgetting the temperature. If temperature is high, you also need to add the paracetamol. Okay, let's go for our final station is for today is this one. Who wants to do?
I can do it also. If
What's your
nobody
name?
Riyad, Dr. Riyad.
You continuously doing it would be your third station. Anyone other than Dr. Riyad?
Riyad.
Any other candidate? No one? I think it's very late. Maybe you guys are having...
We are sleeping.
Here, I guess so. They are tired, might be. Okay, let's go for final station. Okay, you can do it.
Okay. Good morning. I'm Dr. Riyad. I am ED Resuscitaion. May I know your name and your level? I need 2 nurses, please.
Yeah, I am Casey, and I am the APLS provider. Another nurse is Wendy. She's also APLS provider.
Okay, Katie will be allocated for airway and difficult airway intubation. Bendy will allocated for IV access, for monitor and defibrillator, and we will prepare drug. Here we are expecting how old the patient? 5 year, huh? The age of the patient.
Yeah, yeah.
Okay, 5-year-old patient. So we need to prepare our wet flag. So 5 years, so the 10 plus 8, so 18 kg, and for adrenaline it will be 0.1 ml per kg, so it will be 1.8 milligram. Okay, Bandy, also we need to call ICU, PICU team, and we need to call also anesthesia, because at certain point this patient need a certain point intubation. So wash your hand and wear PPE. Is the patient here?
Yeah, patient arrived the other day.
Okay. So any response from the baby?
Patient is unconscious.
Okay. For the history of drowning, is it in short or shallow diving, or it was a swimming pool? How? Because we need to consider C-spine immobilization. It's medical or a medical trauma scenario here.
Fallen canal.
And how deep this canal? It was deep or it was shallow?
It was deep.
Deep. Okay, so no need to protect C-spine here. So we need to dry the child, cover him with dry, dry, cover him and warm. Turn on the turn off the AC, and any response from the baby?
No.
Okay, we need to assess his look, listen, and feel. Any sign of life?
No sign of life.
Okay, please 5 rescue breath, and we after that we check pulse. 5 rescue breath done. What about pulse here?
No sign of life.
No sign of life. Okay, this is cardiac arrest. We need to activate it, code blue, and call for backup team. So here we need to start CPR. 15 to 2, push hard, fast, allow recoil, minimum 100 per joule, minimum 100. Then two rescue breath, and we need to continue for 2 minutes. Please, Kathy, prepare ID access and prepare yes.
Attach the defibrillator page.
Say again.
Yeah. Yeah, I said start the high college CPR 15 to 2 and connect to the back wall mask. Okay.
Yes.
And then attach the cardiac monitor or defibrillator page. And nurse B, please get the IV access, exert the bullet for blah blah. Okay.
Okay. So the nurse B also we need to prepare defibrillator and get IV access, blood investigation with full blood count, biochemistry, hematology, VPG, also toxicology screen. And here we need to consider early intubation. So 2 minutes.
Look at the cardiac monitor. What is the rhythm?
The rhythm is VF. So we need to we need to give asynchronized defibrillation, 5 joule per kg. His weight is 18, so 18 by 4, 32, 72 joule. Please, charging, resume CPR while charging, stand clear, oxygen out, shock, resume CPR. We need to look for a reversible 5H, 5T. Hypoxia is ventilation by IV, by BVM. And we need to intubate this patient as soon as possible. Hypovolemia, we need to give this patient 20 ml normal saline. So his weight is 18, so 216, 32, 360 ml bolus IV infusion. For hypokalemia and hyperkalemia, we are expecting for VBG. Any result, any VBG?
Not yet.
Okay, hypothermia, please cover the baby, the child. And do we need this warm blanket? Cover him with the warm blanket. For trauma, it can be excluded because it was not in shallow diving, so tamponade and tonsor pneumothorax. But for toxin, we need to have further history as per bystander or by family. Thromboembolic also is not we can also exclude because it's obvious history of drowning. And so we need to intubate this patient. I'm skilled to intubate this patient.
No, doctor, 2 minutes past.
Okay, 2 minutes past. What about heart rate now? What about rhythm now? Stop, switch, analyze. What about rhythm now?
Third shock given, still same.
Okay, third shock. Now we need to check temperature. How much is the temperature now?
Is it's now 30.
30. So we can 30. It's limit because below 30 we cannot give the first shock. But if it's 30, we can give the first shock. And we give amiodarone 5 milligram per kg bolus plus adrenaline. We say 0.8 ml, and then we continue CPR. So for
2 minutes, 2 minutes past.
2
minutes past. Yeah, it's sinus. It's sinus rhythm now.
Okay, check pulse, please.
Yeah, patient has pulse. Okay,
great. Team, we obtain ROSC. We need to secure airway here. If anesthesia is here, it will be great if we will intubate the patient. Otherwise, we continue with BVM. We give one breath every 6 seconds. We need to obtain auto-saturation between 94 and 88. We need to obtain normocapnia. We need to maintain normal tension. We need to also to obtain 12 lead. Check glucose, please. We need to maintain normoglycemia. Also, we need to consider here therapeutic therapeutic hypothermia if applicable here. Any handover? Any the anesthesia is here or pediatric is here?
Yeah, it's here. Handover. Okay. Thank you.
So we have the 5-year-old child drowned in pool or. So he was arrived responsive. It was found cardiac arrest. We start CPR. We alert resuscitation team. We give him 3 consecutive shock, and after this shock, as temperature was above 30 degrees Celsius, so we are in right to give the first shock. But before that, we give amiodarone and adrenaline as per wet flag. After that, we obtain ROSC, and patient is now ready to hand over for further care and management. Any question?
No, thank you.
Thank you, doctor.
Dr. Reds, you did great job again. This as you are doing. The thing is that when you going for preparation for that, you didn't verbalize. You know, preparation is always relevant to station where you suspect. For example, it's hypothermia drowning, so you should ask about prepare the towels, okay, blanket, okay, these things. And when you come up, the patient arrives, and also low-grade thermometer. You didn't say it about it. And then when the patient arrives, you also ask the nurse to measure the temperature, and you didn't measure it. You measure when you come up to the shock. Because if you are going for this one, till that patient will be shivering and will die further. That means you.
Here one point.
1 second, let me finish.
Okay,
Then you
okay,
should talk.
okay.
For example, you measure the temperature initially when patient arrive, then you ask them to cover it with the blanket. Number one, first you change the wet clothes, okay, dry the patient and cover with the warm blanket, and turn on the warm air conditioner. But if you don't know the temperature, then these steps will be useless, because it doesn't make sense why you are taking the steps. So that's why I say that check the temperature initially, then you go for the intervention. For example, if they say the temperature is 28 or even below that, so you need to ask them, please, remove the wet clothes of the patient, dry the patient, cover with the blanket, and turn on the warm air conditioner. If there is cold, please close it. So active and passive warming is important. When you go for the oxygen, it should be also warm oxygenation, should be, okay? Warm oxygen, warm fluid, that's very important. And you missed it. Overall, if we say the station went very well, but these are very, very important points which you have to mention. And you went for the temperature in shock. Okay, that makes sense. But this you can again ask when you come for the fourth shock. After third shock, you have to stop. Then you ask the temperature, because you already took the steps for the rewarming. So when you reach the third shock, till that patient either already temperature is improved, okay, then you will go for fourth shock, and then sorry, about the drugs as well after third shock, and then go for, if required, fourth shock. But if you don't go for active passive rewarming initially, then you have to take now, because you know temperature now is below, then you will order now till that patient will die. Means you are going to delay further intervention, which doesn't make sense. Clear so far? Okay.
Yes.
So I think this station also went in adults. If you watch the adult resuscitation, it's almost the same thing. Just the difference is in between them is this is hypothermia in children, which is usually the dose difference, and that is the adult. Overall, everything goes the same way. Okay. Next is about the fluid bolus, which could be the 10 ml per kg. You don't need to go for very deep in it. Just mention 10 ml per kg. Okay, that's it, because this is required. So when you will get the weight, you will know it. If nurse tell you the weight, that's okay, that's great. If don't tell you, just go ahead. You don't have a lot of time to go for it. And regarding post the intervention, it's not your job, but if you have time, you should mention. Okay. That was the last station of the pediatric resuscitation, I guess. And hopefully I will upload these all videos. And I know it's very long to go, but because it's very important, I want everything should be clear to you when it's come up to your exam. And your practice shouldn't be always like the way you are doing, because something can be different. As I did in anaphylaxis, like I make the A stabilize the patient, but in C I make it compromise, so the patient is still in anaphylaxis, and you have to verbalize and you have to take the intervention. Similarly, I do in CRIP. It doesn't mean that all the time you should focus on striders, but you can also focus on other finding too. Another important thing is about the last station. So the temperature should be measured initially and take intervention for rewarming earlier as soon as possible. so you can make your the station smooth and straightforward. Because RKM want to know what they want to from you. For example, in some station, you guys are doing mistake. That's why I make it longer. But if you find the points what I want to check you out, then the station can be very short and you can finish on time. So it all depends on you when you catch the diagnosis, when you do the correct intervention. Once you get the correct intervention, that's it. I will not make it longer because I already got it what I want from you. So why I should make it longer? Okay. So these everything factor depends on you, how you run the station. If you run it correctly, your station will be short and you will finish within 7 minutes, even 6 minutes inside in the station. But if you run the station wrong way, even 10 minutes will be not enough for you to finish the station, because they will test you again and again. You will stuck on the one because you didn't reach what they want from you. So make sure that you're running all station correctly. And I hope you learned something unique today. And thank you very much for coming. Any question?
Yes, doctor. According before this previous recall, not in the group Telegram. I don't find this.
Crope is not in Telegram. That's correct. But this time will be added. I mean is that the Crope, I give you webinar in previous time. I told you you should be very familiar with the scores. If you don't know how to categorize the severities, then you will lose your score. For example, in asthma, you have to categorize accordingly, like life-threatening, acute, severe. This is very important, and that's make you more professional, and you even get it 9 at least for sure. 10 is less likely, hardly ever people get it, but I'm sure about the 9 if you run it nicely. I hope you learn a lot today. And again, one more thing I want to say is some candidates say what is the case and a station should be like inside would be like that. It's not necessarily. It can be like that. Inside can be changed something. Like the station would be like that, for example, in alpha access, but it's not necessarily airway will be compromised or breathing will be compromised. Maybe the C will be compromised. You never know about it. But your suspicion will be likely that. Okay. Any other question?
Thank you.
All right.
For that cardiac arrest, I should in hypothermia should start to ask about temperature early, and I will state that we need to give only 3 shock and stop after the 3rd shock to check temperature when reach 30 degree, and don't give adrenaline unless the temperature is more than 30 degree, and it should be double interval. It should be every 6 to 10 minutes until temperature reaches 435. Yes,
that's correct. This is the same. You did it after 3rd shock. You confirm the temperature again, and that's a good thing. You need to confirm the temperature where is irrelevant, but initial intervention is very, very important because you need to start active and passive rewarming. Some people are running all the time a station the same way, like A, B, C, D, E. No, A, B, C, D, E is okay, but the initial intervention are more important than the A, B, C, D, E. Okay, so sometime you need to take other things to do before go for ABC. For example, in seizing, you need to take a little bit history about medication, about the timer, everything. The same in also in here in hypothermia. So mostly hypothermia always in cardiac arrest, and more common is ventricular fibrillation. So, and about in cardiac arrest, one more important thing is about 4H and 4Ts, which you guys are doing very well. I'm very surprised about you. You're excellent. You're doing very well in 4H and 4Ts. And I already add in adult resuscitation. You can also pick up the point from there. Yeah, hypoxia managed with the back wall mask. So we are satisfied. The hypokalemia depends on the blood result. Do we have blood results? Yes or no? No. So toxin or detention pneumothorax is less likely in here in hypothermia. So you can say they are less likely in this case. The hypothermia is likely the cause here because low temperature. Okay, you need to mention. So we are going for the active and passive rewarming for this patient. So this way you can rule out these all things, and I'm sure the examiner will be very happy about you, that you're really doing great, and they will be really satisfied. So this way you can run the study. Don't skip the 4H and fortes. Never, if the patient in cardiac arrest, because if you one time goes with it, and the next time you will not need any CPR or even the shock, because they satisfied what they want to test you. That's it. You got the cause. That's it. So you don't have to worry about these things as long you follow the guidelines and the correct the intervention. You guys all need practice. Practice will make you perfect. And I spent already a lot of time with you, and I hope you guys will succeed. This is what I want from you. You all should be successful in your exam. My best wishes, and